I think this is good. This magic box. We'll see. It's a live stream for YouTube, so I think you can replay those. I think. I don't know. What was that? Can I up? Yeah, I think YouTube's the same thing. I can post the link. I think. Don't rely on me in case this fails.
Hello? Oh my god. Can you guys hear me without the mic? Put the mic on that thing. It's well a lot of them are blacked out. Like a lot of them aren't coming up. Okay, guys, don't worry, it's not actually that many slides. I'm going to turn the volume down because this is terrible. I'm sorry this is taking so long. Headset. Differentiates these two things is kind of small details. I had to include a lot of the details. If you get to the board, feel free to leave. A lot of this, I kind of tried to switch back and forth between the format of me just telling you stuff and then also like the quiz format. The quiz takes a little bit longer, but keeps I'm going to do it the same way I did the last two, where I'm going to talk pretty fast, and if you have a question or you need me to slow down, just raise your hand. Does that work for you guys? Cool. All right. So somebody said that you liked knowing what you're going to go through. So I put the things. I also put how many slides it is, because otherwise, after we get through spinal tract lesions, and you're like, this is only 4 of like 20, you're going to freak out. But it's like it includes like the first like third of the whole presentation. So, all right. So for Brystax, like recorded things, he says that it's not detailed, but it's super detailed. And so I just went through and I took the stuff that seemed really easy to test for me. And so just the highlights. So for the neurons and Glia lecture, neurons are functional cells. They're permanent. They don't divide. Nissl substance is what you call the rough ER. Dendrites do signal reception. Axon hillock is where the action potentials originate. Make sure you know the difference in the absolute and relative refractory periods, because that's really easy to test. Absolute refractory period just means no matter how much impulse, so it's generally after you get an action potential, you'll enter a refractory period. If it's an absolute refractory period, then it doesn't matter how much stimulation it gets, you're not going to get another action potential. Relative refractory period just means it takes a larger stimulus to get that same response. Glia is kind of the general term for support cells in the nervous system. So like microglia, astrocytes, those are types of glia. Microglia are the macrophages of the nervous system. Astrocytes are kind of the do-everything cell. So they do electrolyte balance. They're what forms the scars. Their foot processes are one of the 3 things that form the blood-brain barrier. So basically, if you have a question, it's asking what cell type does X. If you don't know, astrocytes are a pretty good guess. Schwann cells and oligodendrocytes are the ones that do the myelination. Schwann cells are going to be your peripheral nervous system. Oligodendrocytes are going to be your central. And then again, something that's pretty easy to test is Schwann cells are 1-to-1. So one Schwann cell is going to myelinate one axon. Oligodendrocytes kind of look like octopuses, and they extend out to a bunch of different axons around them. So one oligodendrocyte can myelinate multiple surrounding axons. Satellite cells, another type of support cell. The terms for them were really vague: insulate, nourish, regulate local environment. I would say more important for that is just knowing what they look like on histology. You guys have that histology, that online histology thing. And then ependymal cells are the epithelial lining. Okay, so this is just a demonstration of what all of those are. So you can see an astrocyte goes out and does the end foot by the pia-mater, and then they're also, this is also an astrocyte, so it's also involved in the blood-brain barrier over here with the ventricles. You have ependymal cells lining the ventricles. And then you see the oligodendrocytes are around an axon here, on an axon here, on that axon, they're all over the place. Okay, so that's all for neurons and glia. For synaptic transmission, there were a lot of things that you could oppose in this, a lot of like groupings. So electrical synapses, which are the low resistance, high conductance with gap junctions, versus chemical synapses, which do not have direct contact, and they do the neurotransmitter. So that's where you have the presynaptic, where you release the neurotransmitter, and then it binds postsynaptically. I would say one important thing to know about this that Frastek really emphasized was that this is the active zone, and he really emphasized that that's where the neurotransmitter is bind. Okay. Another important thing is the duration of the action potential is what determines the strength of the postsynaptic response. So the presynaptic neuron is going to determine the duration. So the duration of action potential in the presynaptic neuron is going to determine the strength of the response, because it's going to determine how much neurotransmitter is released. But the properties of the receptor, so the postsynaptic cell, is going to determine the type of response. Because if you think like acetylcholine, it can be released by a bunch of different cell types, right? But its effect on the postsynaptic cell is going to determine what type of receptor it binds. Okay? And then talking about receptors, we have the directly gated receptors, which have ion channels in them. Those are going to be the fast-acting, and they're going to have short responses. They get bound, and they immediately do something. Indirectly gated are a bunch of ones that you've learned about. So the G protein coupled receptors, they have second messengers. Second messengers are released and they kind of diffuse within the cell, so it's going to be a slower response, but it usually has a longer impact. And these are just the pictures of those. Yeah.
So is the picture in the right corner there, is that a postsynaptic cell? With the active zone?
I believe so, yeah. I think the chemical the neurotransmitters that we find it, yeah.
Okay.
I'm trying to remember. Don't take that 100%. Okay, yeah, you're right. No, this is presynaptic. Where the vesicles bind.
Okay.
My writing confused. This is presynaptic cell. As Arfan pointed out, these are vesicles that are going to bind there to your list. Sorry. Thank you, Arfan. All right, so for synaptic transmission, you need to know the difference between temporal summation and spatial summation. So both of those are types of synaptic integration. So the axon hillock is what he talked about as like the calculator kind of. So it adds all the excitatory signals, which are the EPSPs, and the inhibitory signals, which are the IPSPs. And if those ever get to a high enough point to depolarize, then it'll send an action potential. So the two ways that it can sum can be temporal summation, which talks about once a signal gets the axon hillock, how long does it still affect it? And that's generally going to happen when you have one neuron sending multiple signals separated by time. So if it sends one signal every, like, for example, 2 seconds, if that signal only hangs around for 1 second, then those signals never add up, right? Because it sends one, and then by the time the next one comes, the first one is dissipated. But if those signals hang around for 5 seconds, then they can add up and they can get to a point where we'll make an action potential. Spatial summation is how far the signal will propagate, and that's going to be, that's usually multiple neurons sending signals to one place. And basically, from how far away of a neuron can this neuron read signals. So time constant is how long it hangs around, length constant is how far it travels. And then you have the types of synapses. I'm not going to go through these because you guys know how to read, but I would just make sure you review these. And then this is super important because he really emphasized this, the presynaptic mechanisms, that for the propagation of the action potential to the presynaptic terminal, you need the sodium and potassium channels. but then the actions actually at the presynaptic terminal are determined by calcium. Okay, and then again, we've all learned this a million times, but make sure you refamiliarize yourself with how vesicles are released. All right, again, you guys can read this. I'm going to read it to you. Okay, so that's all the FRASAC stuff that I looked at. Yeah, whatever your heart tells you to. A couple of mnemonics from Dr. D that I still think about a lot are slow aim. So slow aim, superior colliculus, lateral geniculate are for the optic tract. And then aim, auditory tract, has the inferior colliculus and the medial geniculate. And then C. raphe, substantial dopey blue knees. So C is serotonin, which is made at the raphe nucleus. Excuse me, dopey is dopamine, which is made at substantia nigra. Blue knees, blue is for ceruleus, locus ceruleus. And then knees being norepinephrine, so locus ceruleus produces norepinephrine. And then his second one thing was Uncle Maynard forgot to take his cholinergics. The nucleus of Maynard is where you get acetylcholine. So that might seem really random, but it's helpful for things like remembering that Parkinson's disease, which is dopamine deficient, is as a degeneration of the substantia nigra. Okay, so cranial nerve modalities. Obviously, you need to know all 12 cranial nerves. The mnemonic that my mom taught me is oh, to touch and feel very good vaginas, yes, from my mother. And then for remembering the modalities, so whether a given cranial nerve is sensory, motor, or both, you can use some say marry money, but my brother says big boobs matter more. And that'll take you 1 through 12. All right, and then for remembering the anatomy, so neuro can be super, super confusing if you see like a stroke is here and it has these 7 unrelated things. You're like, how the hell are all of those things the same? The easiest way to like really understand neuro is to know the neuroanatomy behind it, and then you'll understand why these like seemingly unconnected things happen together. So just general organization, the rule of 4s is that 4 of the cranial nerves come out above the pons, so that's 1 through 4, and then the next 4, which is 5 through 8, come out at the pons, and then 4 below the pons, really the medulla, so 9 through 12. We say above the pons because 1 and 2 are in the cerebrum. 3 and 4 are midbrain. The important thing about 4 is that it's the only one that comes out of the dorsal side, and it's the only one that crosses. 5 through 8 are in the pons, and then again 9 through 12 below the pons. One thing that Dr. McCoy emphasized with you guys was that the pure motor ones, which are factors of 12 except for 1 and 2, so 3, 4, 6, 12, are medial, and that is a general spatial organization of the brainstem. And this was from the old PowerPoint that don't need to know GBE, SBA, et cetera, to the extent you did last year. I still think that's true, but McCoy did talk about that more than Dr. Merchant did with us. I've also heard mixed information about whether or not they're rewriting the test questions for you guys, so I don't know what is necessarily emphasized on the test. I did completely change this from last year. Like, I did go through all the lectures for this year and make sure the information is the same, but obviously I'm not taking your thing, so. I would be really surprised if you needed to know, like, GBA, SVA, though. Okay. Cranial nerve reflexes are important to know because that's, like, easy points. So the pupillary reflex, 2 in, 3 out. Corneal, 5 in, 7 out. Lacrimation is also 5 in, 7 out. Jaw jerk, 5 in, 5 out. And the gag is 9 in, 10 out. Okay, so cranial nerve 2 damage. You should be able to look at this and figure out where the lesion is. So if you look at the top, both eyes are dilated. When you point the light into the right eye, neither eye constricts. When you point the light into the left eye, both eyes constrict. Yeah.
No, just the last one. What do you mean when it goes in and out?
So what's the afferent branch of the reflex? What nerve senses the reflex, and what nerve makes it happen? So, like the pupillary reflex, 2 senses the light, telling your brain, hey, reflex needs to happen, and then 3 actually constricts the pupil.
Oh, okay.
So it's what sense. So corneal reflex. 5 is sensation of the eyeball, so 5 senses, hey, there's something touching my eyeball, and 7 is what closes the eye. So 5 is the afferent limb, 7 is the efferent limb. Afferent and efferent are just sound really similar, so I just say in and out. Okay, so if you look at the top one, if you point the light in the right eye, neither pupil constricts. If you point in the left eye, both pupils constrict. So what this tells you is that both eyes have the ability to constrict. So it's not a cranial nerve 3 problem, but since neither eye constricts, you point it in the right eye, it means the signal is not getting in. So cranial nerve 2 is what carries the signal in from the right eye, which tells you that this is a right cranial nerve 2, also known as the optic nerve lesion. Yeah.
Which row are we paying attention to?
The top row.
Okay.
Okay, so then that's explained at the bottom. Neither pupil constricts when light is shown in the ipsilateral eye. Both pupils constrict when light is shown in the contralateral eye. If we look at the second row, you can see that at baseline, the right pupil is more dilated than the left pupil. When you shine light into the right eye, the left eye constricts. So the signal is getting in because one of the eyes is reacting. When you shine light into the left eye, also just the left eye constricts. So the signal is getting in, so cranial nerve 2 works on both sides, but the right eye is not constricting, so the problem is with cranial nerve 3 on the right side. So oculomotor nerve damage, dilated ipsilateral pupil that doesn't respond to light shown in either eye, contralateral pupil responds to light shown in responds to either eye. Okay, go ahead and read this. Right optic nerve is exactly what we just talked about. Since both pupils constrict on one and neither constrict on the other, when neither constrict, it means the signal is not getting in.
The tract is going back to the occipital lobe?
Mm-hmm.
Okay.
All right. So this is showing. So this is what Dana just talked about. This is showing the optic nerves, the optic tract. So we're just going to go through lesions at different spots, what visual problems they cause. So just think about A for a second. All right. So for A, you're going to get, if you cut off it off right there, you're going to get complete blindness just in that eye. B, right in the middle there. So B, you're going to get the bitemporal heteronymous hemianopsia. I'm sorry. Yes. So bitemporal, here's nasal, here's temporal. So bitemporal, you've lost both temporal fields. Heteronymous means different. So a homonymous hemianopsia is either they're both left-sided or they're both right-sided. And then hemianopsia, hemi meaning partial, anopsia meaning loss. Okay, and then C. So for C, you're going to get the ipsilateral nasal hemianopsia, and you can see that just from looking at where those fibers came from. And I don't think you really see that a whole lot in real life. Okay, and then for D, so you cut off the entire optic tract on the right, and so you're going to lose the left visual field of each eye. Okay. E, you lost the upper part of it, so the part that goes through the parietal lobe on the right, so you lose lower left vision. Okay, F is just you lost the lower part of it instead of the upper part of it. And then G, so you lost the entire tract at the very back. The only thing that's different, the way you can tell that versus losing it somewhere farther up, is that when it's at the very back, you get macular sparing. I don't remember the exact reason. The macula has dual innervation. I don't know where the other is. There we go.
Well done.
Yeah, well done. Okay, so some rules of thumb. Monocular vision loss, meaning vision loss in one eye, is going to be anterior to the optic chiasm, so it's going to be retina or optic nerve up there. Binocular loss is going to be at or behind there. So the lesion is going to be opposite of where you lose the visual field. So if you remember that parietal lobe is above the temporal lobe, if you lose like bottom left visual field, it's a top right lesion. So bottom left visual field loss, so E is right parietal. So it's just the complete opposite. If you lose top right visual field, it's bottom left, so it's left temporal. Does that make sense? I'm getting some blank stares. Okay, cool. Okay, yeah, macular sparing, dual innervation. Okay. Here's another cranial nerve 3 lesion. So the whole picture of what you can get with cranial nerve 3 lesions is that it will be down and out. So you can see this guy's trying to look straight at us. This eye is pointing straight at us. This one is down and out. And that's because cranial nerve 3 does 4 of the muscles with superior oblique and the lateral rectus are the only ones it doesn't control. So the lateral rectus is going to be unopposed pulling that eye out, and the superior oblique is going to be unopposed pulling that eye down. All right, you get the double vision because if your eyes aren't lined up straight, you get double vision. The important thing to know about this is that it is generally horizontal double vision. It can be a little bit vertical too, but it's usually horizontal. You also get ptosis, which is eyelid droop. And it's because you lose the levator palpebrae superioris muscle. And so they might be walking around like this with their eyebrows really high, trying to keep their eyelid up. So the important thing is to differentiate this from Horner syndrome. You also get ptosis from Horner syndrome. The difference is that Horner syndrome is a loss of sympathetics. So sympathetics usually dilate the eye, and the way you can remember that is if like sympathetic is fight or flight. If you're trying to decide if you want to fight something, you probably want as much like visual information as possible. So you're going to dilate your pupils to try to like take in as much light as you can. So for Horner syndrome, you still get the ptosis because the eyelid has 2 different muscles, it's dually innervated to pull it up, but you're going to get a dilated pupil versus a cranial nerve 3 lesion, you're going to get with Horner's you get a constricted pupil. Cranial nerve 3 lesion, you get a dilated pupil. Because it's parasympathetics. Sorry, that was confusing. Do you want me to go over that, or do you guys get it?
Go over
Okay. Cranial nerve 3 has parasympathetics. Parasympathetics normally constrict the pupil. So if you lose cranial nerve 3, you're going to have a dilated pupil. Horner syndrome is a loss of sympathetics. Sympathetics normally dilate. So you lose sympathetics, you get a constricted pupil. Both of these things are going to have ptosis because sympathetics and parasympathetic, or sympathetics and cranial nerve 3 both innervate eyelid muscles. And with cranial nerve 3, you're going to have down and out. Horner's doesn't affect extraocular muscles. You also lose accommodation. Okay, cranial nerve 4 lesion, you have the outward rotation, and so the way that you're going to see this on a test question is they're going to be tilting their head. And they're going to be tilting, so they tilt their head away from it. So when they tilt their head, the eye that's affected is the superior eye. You get vertical double vision, so that's in contrast to 3 or 6, which would give you horizontal double vision. And then cranial nerve 4 does the superior oblique, right, which allows you to look down. So if you can't look down, another thing that you often see in test questions is if you have a cranial nerve 4 lesion, you have a lot of trouble walking down the stairs because you can't see where you're going. Are there questions about that? Some people are making faces.
Just
Also, book reading as well, right?
What?
They can't read a book as well. So it's not a book on the test, so also read a book.
That's not like a test hint that I know of, but I would imagine it's difficult with the extorted eye.
Just to be clear, I understand vertical double vision is they're stacked, the 2 images? Okay.
Yeah. So I actually didn't realize how big of a differentiator this was until I did my neuro rotation, and every time somebody has double vision, the attending would ask, okay, are the 2 of me standing side by side, or am I standing on top of myself? Because apparently it's just like a really fast way to figure out which nerve is messed up. Okay. Cranial nerve 6. So if we look at the top, he's trying to look straight, but you can see that his left eye is a little bit medially directed. If he looks to his right, it's totally fine. He can move both eyes to the right, fine. When he tries to look to his left, his right eye moves, his left eye stays looking straight. So he's having trouble abducting his left eye. And the reason when he looks straight that it's a little bit medially directed is because that medial rectus has nothing opposing it. So inability to abduct, and then you get a horizontal double vision. So one way that they compensate is they just turn their head instead of turning their eyes.
Hey, Jacq, for a question, how can they would have to tell us what direction he was trying to look in, right? Like it's like you told us that the first one he's trying to look at us straight so that we knew what eye was messed up.
Yeah, but you can also kind of tell by looking at the first and then the second picture Because like if he were trying, because like where else would he be trying to look in that first picture, like if they didn't tell you? Because like if you only saw that picture, you'd be like, okay, I don't know if he's trying to look right or trying to look straight. But then you look at the next picture, you're like, okay, he clearly can look right.
Okay.
But they're generally going to tell you. But if you just, they have to either tell you or show you multiple things like this picture. Okay. So MLF is like kind of important and confusing. But basically what happens is, if you want to look left, then the PPRF, which is back here, gets activated, and then it goes up and it tells the abducens nucleus, hey, I want to look left. So the abducens nucleus fires cranial nerve 6, so that the left eye can AV duct, and then it also sends a signal along the MLF to tell cranial nerve 3 on the right that the right eye needs to AD duct. And so the lesion that you get with this is called internuclear ophthalmoplegia. So the classic presentation of this lesion on a test is that when they try to look left, assuming that this is the MLF we're talking about, when they try to look left, they have a lesion in that left. So they get the signal here, they get it here, and it fires, and it tells the left eye to look left, but the right eye never gets the signal to look left. And so the eyes are like this, left eye will look left, right eye stays like this, but it's really unnatural for your eyes to be pointing different directions, so you get nystagmus. So your left eye starts beating back towards the right. And the nomenclature for this is whichever eye does not AD duct, that's the side we say is like a right internuclear ophthalmoplegia, if the right eye doesn't AD duct. I have trouble figuring out which side it's on, but with whichever side cranial nerve 3 does work on. And the way that you can tell the difference between that and just like a problem with the medial rectus is that they're still able to look centrally during accommodation. So that's when you do this, and their eyes will still, both eyes will AD duct. And then the other way that this can manifest, and this was the case that Dr. McCoy did with you guys.
Jackie, sorry, can you just repeat that last thing, or can you repeat that last thing you just said?
Yeah, so if I'm trying to, if these are my eyes, and I'm trying to look to the left, this eye moves, this eye doesn't, okay? The way you can tell that this is an MLF problem instead of just the medial rectus on my right eye isn't working is that you do accommodation, which is where you like make them cross their eyes, and when they do that, both eyes will AD duct. So the medial rectus is fine. They're still capable of AD ducting. It's that the signal pathway is interrupted. Yeah, so if you have a lesion in the actual MLF, then you'll get the classic, this eye moves, this eye doesn't, and this eye beats back. If you get a lesion in the abducens nucleus or the PPRF, then when they try to look left, nothing happens. Neither eye moves. And that's not a problem with like the medial rectus itself or the lateral rectus. It's just nothing is telling either eye to move. And so that's the way you tell the difference between an MLF lesion and an abducens nucleus or PPRF lesion. Does that make sense?
A stroke would cause that as well, right?
Yeah, lesion just means problem. So a stroke of the PPRF is a type of lesion of the PPRF.
Would anything else cause the twitching of the eye besides the defect in the MLF?
So nystagmus can be caused by like a decent number of things. It can be caused by alcoholism, it can be caused by vestibular problems, cerebellar problems, there are like a decent number of things. If it's internuclear ophthalmoplegia, it'll be fairly obvious in the test question. Like they have to tell you, they have to either show you that picture with their eyes like this, or they have to tell you when they tried to look left, the right eye didn't move and the left eye beat back. Like once you know about it, it's pretty easy to pick out. Okay, read the question, please. We haven't gone over this, you guys might not know this, it's just wanted to tell you so that you would have some clue. Okay, so the fact that it constricts during accommodation tells you there's not a muscle problem, right? It can constrict fine. So it's the actual light reflex that's the problem. And this was just the way of telling you the light reflex is in what's called the pretectal area. There's not really any, I'm not gonna go over like the whole track or anything because I don't think it's very high yield, just might be something worth being able to recognize. No, Argyle Robinson accommodates but does not constrict, yes. Oh, yeah, so one of the memory tricks for Argyle Robinson people is, this is not my thing, this is what it is commonly called. It's called the prostitute pupil because it accommodates, but it doesn't react. So that's just, it's an easy way to remember that. All right, here's another question. All right, right-sided ptosis, right eye is down and out. This is probably a cranial nerve 3 problem, right? Ptosis, we're either Horner's or cranial nerve 3. Down and out, that tells us it's cranial nerve 3. If they're giving you a medical history, there's usually a reason why. And so in this case, the reason is because they're telling you he has diabetes, which can cause neuropathy. Specifically can cause cranial nerve 3 neuropathy, which is a form of ischemia. Because that's what diabetic neuropathy is.
Oh, it's specifically ischemia, not like inflammation.
Yeah, it's ischemia.
And the lacunar stroke would have different.
Well, lacunar stroke wouldn't affect cranial nerve 3. I don't think. And there are longer explanations for most of these questions in the comments below the slides. Okay, impaired vision, increasing difficulty when looking sideways, has to completely turn its neck to look to the side. Okay, pretty much anytime they talk about vision problems while driving, they're basically trying to get at the bitemporal hemianopsia, which is going to be caused by a pituitary tumor. In this question, they made it even more clear with the decreased libido. So you start to think like endocrine problem. So decreased vision in the temporal fields on both sides. So this is going to be a craniopharyngioma, which is the tumor that can press on the optic chiasm. So anytime they talk about like the bitemporal visual loss, you got to think optic chiasm, and they're pretty much always getting at a tumor pressing on it. I know that's like not super obvious. It's just a thing you got to know, and then you'll be able to recognize it. Okay, cranial nerve 5. Got to know trigeminal neuralgia, lightning-like jabs of pain in V2 or V3 brought on by chewing, talking, or even like light touch will do it. Etiology, if you get this in someone who is not elderly, then you need to check and see if they have MS, so see if they've had other lesions in the past. For an older patient, it's usually a blood vessel that's compressing the nerve root, and it wears all the myelin off the nerve. Treatment, if it's an old person, you can do that pad thing there, or move the blood vessel, otherwise carbamazepine, and this is like a one-to-one thing, you just have to know that carbamazepine is a treatment for trigeminal neuralgia. Other cranial nerve 5 lesions, if they're lower motor neuron lesion, then you do get jaw deviation, and it goes towards the side of the lesion, and you get atrophy. For upper motor neuron, you actually do not get any deviation because you have dual upper motor neuron innervation. And we'll talk about that when we talk about cranial nerve 7. I wouldn't worry that much about cranial nerve, about the jaw lesions. Oh great, cranial nerve 7, cool. Okay, so cranial nerve 7, so facial nerve, talking all the muscles of the face, right? So when you think of the classic stroke symptoms of like the droopy half of the face, that's cranial nerve 7 strokes. Do you guys know what a lower motor neuron and upper motor neuron are? Okay, so cranial nerve 7 is the lower motor neuron. The upper motor neuron of cranial nerve 7 goes from the cortex to the brainstem.
Are all cranial nerves lower motors?
Lower whatever. They don't all have motor components, but yes. So they are all the lower neurons, which is why you could also like get a stroke in your frontal lobe and lose innervation to your face, right? It's not it's because the thing that goes to the cranial nerve that goes to the face is being affected. So the lower motor neuron, meaning actual cranial nerve 7, you will get ipsilateral paralysis of the upper and the lower face, so the entire face. And so you can see that here. So this is the lower motor neuron. If you hit that, you hit all the fibers coming in. So you lose upper and lower face. You also, if you remember, cranial nerve 7 does the salivary glands except for the parotid, so you're going to get dry mouth. You get decreased taste because it does taste to the anterior 2/3 of the tongue. And you could also get increased sensitivity to noise if it hits the chorda tympani, because remember the stapedius is what like protects your ears against noise, and 7 innervates stapedius. Upper motor neuron, you only get weakness of the lower face. And the reason is that the part that goes to the upper face has dual innervation from both sides of the brain. So if we knock out this, then we've knocked out the entirety of the part that goes to the lower face, but we still have this part, that part for the upper face. So you're gonna get weakness of the lower face, upper face is gonna be fine. I can almost guarantee you this will be a question on your test. It's gonna tell you, it's either gonna show you a picture of somebody with or without forehead weakness, and what you look for is that their forehead is smooth. They're gonna say, when told to raise their eyebrows, this is what it looked like, and you'll see wrinkles on the unaffected side, and it'll be smooth on the affected side. You're going to see either an entire face or just the lower face, and it's going to ask you, was this an upper motor neuron or lower motor neuron stroke? Yes.
So the lower motor neuron is ipsilateral, and then the upper motor neuron that comes from the cortex is contralateral, right?
No.
No.
Lower motor neuron, lower motor neuron, yes, is ipsilateral.
Okay.
So just like how the right side of the cortex controls like the whole left of the body, it also goes to the left brainstem. And then that comes on the left to the left face. So yeah, brainstem stuff in general is ipsilateral, but the upper part of those neurons is contralateral. Yes.
You said the forehead would be smooth, does that mean that means that there's,
If the forehead is smooth, it means it was lower motor neuron and the forehead is affected.
in the forehead?
So what they're going to do is they're going to show you someone trying to raise their, if it's a full face thing, they're going to show you someone trying to raise their eyebrows, and they'll do it on one side. See when I try to raise my eyebrow, like furrows here,
Yeah.
but when I don't, it's smooth. So what you're going to see is on the unaffected side, they're going to have furrows, and on the affected side, it's going to be smooth because that muscle's not working.
Okay. And just to clarify, did you say all lower motor neurons are cranial nerves like 7? No, all cranial nerves?
No, all cranial nerves are lower
Are
neurons.
lower,
So
okay.
they all have an upper neuron that goes from the cortex to the brainstem, and then the cranial nerve goes brainstem to wherever it innervates. I mean, 1 and 2 don't start in the brainstem, but you know what I mean. Okay. I didn't really see a lot of vestibular and auditory stuff in your guys' lectures. Okay, so the slides are still in the PowerPoint, but I did the like hidden slide thing. So you can still go look at the slides if you want, but we're not gonna go over them. All right, we're gonna get through 9, 10, 11, 12 real quick. All right, for a lesion of 9 and 10, and they're usually together, the uvula will deviate away from the side of the lesion. So 10 raises the back of the soft palate. So if this is soft palate, my hands are the uvula. If I raise this side, it's going to swing the uvula towards that side, right? So if I have a stroke on this side, this muscle doesn't work. So I raise it, and it points towards it points towards the healthy side. Oop, see, right there. All right. So uvula deviates away from the side of the damage. So it's going to point towards the healthy side. You get impaired speech, ironic, and swallowing. You get hoarseness because cranial nerve 10 controls the vocal cords, and you also get the decreased gag reflex. So the afferent branch of the gag reflex is 9, and the efferent branch of it is 10. So if either of those are affected, you get a messed up gag reflex. So hoarseness is going to be 10. Uvula is going to be 10. I don't think you're generally asked to choose between 9 and 10 because they share the same nucleus. Okay, so for an 11 lesion, 11, as you remember, does that, and it also does the SCM. So sometimes people have trouble remembering which SCM turns in which direction. So the way you can remember it is that if a muscle contracts, then it gets shorter, right? Obviously that's the definition. So if you know the SCM goes here to here, if you put your hand there, when you turn towards there, your fingers get closer together, so you know that that's the muscle contracting. Your fingers get closer together, and then you turn that way, those two fingers get farther apart. So the right SCM turns your head to the left, because that's when the muscle contracts. They get closer together, I promise. It's giving me such weird looks. The right SCM turns to the left. So if you mess up the right so if you lose the right cranial nerve 11, or you lose the right, so if you lose the right cranial nerve 11, then the right SCM doesn't work as well, so you can't turn to the left. So SCM goes here to here. So when I do that, my fingers get closer together.
Wait, what? Isn't that opposite?
And you also get weakness with raising your shoulders. And so you can see the top picture, that left shoulder is drooping because they have a left SCM problem, so their trap's not working. Okay, and then a 12 lesion. This is the lick your wounds. The tongue deviates towards the side of the lesion because the muscles that are sticking out the tongue are, in this person, they're working on the left, and so it gets stuck out more, and the right is shorter, so like the left goes forward, the right pulls back, so you end up turning to the right. Just remember lick your wounds. Okay, read this. There's a lot of extra information there. What it's really asking is which cranial nerve does sensation of the cornea? Which cranial nerve does sensation in general of the face? 5. Okay. Okay, so this is kind of the same thing as the 2 versus 3 with the light going in, both contracting and contract. So it's important to think about when you have a problem, especially when it's different nerves taking the signal in versus bringing the signal out. Is the problem that it's not being detected, or is the problem that it's not being able to respond? So if they have a cranial nerve 7 lesion, 7 is motor, and so the problem is that they are not able to do the motor response on the right. The corneal reflex is that when 5 senses touch on the cornea, both eyes blink. So 5 is what brings the signal in, 7 is what brings it out. So 5 is working on both sides, so they get the signal in, and then the 7 on both sides is going to tell the eyes to blink. But 7 on the right is not working. So both eyes try to blink, the right just doesn't do a good job. Any questions on that? Okay, so I posted a video on your guys' Facebook wall a couple of weeks ago of how to localize brainstem strokes. It's like super, super, super helpful. I also put the link in the comment for this, and I'm just going to go through this with you real quick. So this is what I used for Neuro second year. It's what I used for STEP. It's what I used for Neuro this year. It's super helpful. So this guy makes a tic-tac-toe board, and so the top row is midbrain, middle row is pons, bottom row is medulla, and then we have medial, and then both lateral. So if we draw the cranial nerves, 3 is medial midbrain, and then we double that to 6 for pons, double that to 12 in the medulla. 7 is on the line there, because it can be affected by medial or lateral strokes. And then the V's, one of those V's is for 5, for trigeminal nerve, and one of those V's is for vestibular. And the reason they're on the line is because the trigeminal nucleus is really tall, and so it can be affected by a pons stroke or a medulla stroke. Okay. And then the nucleus accumbens has 9 and 10 in it. That's why I was saying they're really never going to make you pick between 9 and 10 because they have the same nucleus, so generally a stroke that affects one is going to affect the other. Okay. ICP, inferior cerebellar peduncle. So cerebellum does balance and coordination. So this is just telling you that if you have a stroke in the lateral medulla, it can affect the cerebellum. There's also the MCP in the lateral pons, so lateral pontine strokes can also affect the cerebellum. And then you draw in the tracts. So corticospinal tract goes straight up the middle. Dorsal column is slightly lateral to that, and then at the midbrain it goes even more lateral. So it's medial, medulla and pons, and then lateral midbrain. And you guys learned that these decussate in the medulla. They decussate at like the very, very bottom of the medulla, and so so consider them already decussated if you have a medulla problem. Okay, and then spinal inflammatory tract and sympathetic are lateral. I just remember S and S are on the outside.
Do we not do 4 for a reason?
I'm sorry?
Do we not do cranial nerve 4 for a reason?
because it's on the dorsal side, and so it's not generally affected at the same time as other cranial nerves. So you'll see like 1 and 2 aren't on there either because they're just not physically in the same space. And this is obviously an oversimplification, but it helps a lot. So then obviously what you gotta know if we're trying to localize strokes is what artery is having the stroke. So the top 3, the posterior cerebral artery does all of the midbrain. The basilar artery does the medial pons, and then the ICA, the anterior inferior cerebellar arteries, do both lateral pons. Anterior spinal artery does medial medulla, and then pica does lateral medulla. So you can see, if we talk about, you guys learned about lateral medullary syndrome or Wallenberg syndrome. It was one of the cases in Dr. McCoy's lecture, and it's a super, super highly tested thing on STEP, and I would be very surprised if you found a question about it on your exam. So when you get that, you get all of these symptoms that seem totally unconnected, but then if you look on this, they're all right here, and that's why you get it. And we'll go over that. All right, let's do this question. All right, so loss of sensation on the face. What does sensation to the face? 5. All right. Pinprick sensation for the face and the body are normal. And then tactile sensation on the body is normal. So this is a 5 lesion, and so one of the ways that they can ask you about that is they can basically ask where is the nucleus for 5. So this might seem a little bit excessive to be talking about all those different things, but a lot of the cases and like test questions you get will talk about a bunch of different deficits. So the way that I find most helpful to approach this is to have a piece of paper and then for each deficit to write down the deficit and then what area is associated with it. And then after you've gone through the whole question, you look at all those areas and say, okay, where do all of those intersect? Like what could cause problem with all of these different cranial nerves or all of these different tracts or whatever. So for this one, lifting something, sudden pain in the back of his neck. So right-sided ptosis. So we're thinking either cranial nerve 3 or Horner syndrome, right? Cranial nerve 3 or sympathetics. Decreased pinprick on the left body and right face. Okay, so cross-body findings, you always think brainstem. So that right there alone tells us that this is a brainstem problem. So decreased pinprick on the left body and right face. So that tells us it's going to be the right spinal thalamic tract, right? Uvula that deviates to the left. Okay, so what's that problem? 10 on the right. When he tries to walk, he falls to the right. So you guys may or may not know this, but cerebellar problems make you fall towards the side of the lesion. So that's a right cerebellar problem. He sounds hoarse. Oh, I might have messed that up, shouldn't I? No, sorry, it was not messed up. He sounds hoarse, so 10. So what vessel is most likely affected? Okay, so we have a problem with cranial nerve 10, we have a cerebellar problem, we have a spinothalamic tract problem, and we have a cranial nerve 5 problem. So all of those intersect in the lateral pons. Lateral medulla. So this is pica syndrome. And so left body, right face, falls to the right. So this is right-sided pica. There you go. So many questions. One second. Yeah.
Maybe not for this exam, but just in general, do you find it important to know the names of the specific lesions like Wallenberg?
No. They will, on step 2, 2 in general, they will never ask you if, sorry. On step 1, they're never going to ask you like an eponym if there is another name, and they almost never ask you to diagnose people. It's always a step 2. It's always a 2-step question. So they're never going to say, what is this syndrome? They're going to say, what's the artery affected, or something. Like this would be a pretty typical step 1 question. Alice.
Is the pica supply of cerebellum? Is that why it's cerebellar?
Inferior cerebellar peduncle. Yes, it does, but it's the peduncle right here. Yes.
So on the last one, when it was pons, the reason why it's not medulla because there's no end, like you can't say it's like right on the mid
It's because I didn't put medulla as an option.
I just read it.
And that could be a pons or medulla problem, which is why medulla is not an option.
Okay.
Because you're right that nucleus runs like through the entirety of the pons and medulla, so since this is like an isolated cranial nerve 5 problem, could be either one.
Okay.
That's why I didn't. If I can figure out how.
It might ruin the video for those who wanted it. I don't care. What?
I don't think it might not be that.
It may not.
Okay.
It may not.
All right. So this is what I was saying before. Cross-body findings pretty much tell you that it's a brainstem lesion, and that's because the spinal inflammatory tract decussates at the level that it comes in. So if I have a left-sided problem, spinal inflammatory tract's going to come up on the right side. So if the right side of my brainstem is messed up, it's going to get rid of stuff on the left side of my body. But all of my cranial nerves are ipsilateral. So if the right side of my brainstem is messed up, all of my right cranial nerves will be messed up. So cross-body findings are their way of telling you it's a brainstem problem. And the lifting something with sudden pain in the back of your neck is a vertebral artery dissection, just so you guys know, which can cause pica infarcts. Okay, this is like kind of a weird thing. Just something you kind of have to know that Dr. McCoy went over in his lecture is that cranial nerve 7 wraps around cranial nerve 6, so they're often affected together. That was really the point of this. Yeah, and then this lesion is what we talked about earlier with the MLF, where if you get a PPRF or an abducens nucleus problem, when they try to go lateral, neither eye moves.
Jacq, quick question.
Yeah.
How can you tell, like, if you know something's like a cranial nerve issue, how can you tell if it's like the nerve outside the brainstem versus what it's like in the brain side?
So if it's so for 3, you gotta look where the visual field is messed up. For 2. For other stuff, you're really gonna have to just know if there's another problem also.
Okay.
And then most of the time we're talking about like lesions, we're talking about strokes, and those are gonna be in the brainstem.
Okay.
So basically it's brainstem unless proven otherwise.
So in this particular example, it's mostly the nuclei that's being affected and not necessarily the cranial nerve.
This is the abducens nucleus or the PPRF. It was the abducens nucleus. So cranial nerve 6 is the abducens nerve. So the nucleus of cranial nerve 6 is the abducens nucleus. Cranial nerve 7 wraps around that. And so 6 and 7 are both affected. And the reason neither eye moves is the thing we were talking about earlier with the MLF, because the abducens, if you're trying to look to the right, in this case, the abducens nucleus tells the right eye, hey, lateral rectus, look right, and the abducens nucleus is also what initiates the signal that goes to the MLF, telling the right eye to look right. The left eye to look right. Yeah, there you go. All right.
Will they ask us to identify MLF on a cross section?
No. I don't think so. I don't know, but I would be surprised. I have no idea where it is in the cross section. All right, so spinal cord, dorsal column, Vibration and proprioception comes in through the dorsal root. Remember, dorsal root is sensory, ventral root is motor. You remember vroom vroom for motors. So it ascends either in the fasciculus cuneatus, which is the upper body, and this can be the more lateral one, or in the fasciculus gracilis, which is the lower body, that's going to be more medial. So the distribution for this is as if it really is a person. Because like when you stand, your legs are together and your arms are on the outside. So same thing here. Leg, so this is gracilis, and the arms are on the outside. So gracilis is the lower body. It's named after the gracilis muscle in the legs. They're going to ascend, and then at the like very, very, very lower medulla, the pyramids, they decussate there and then start ascending the medial lemniscus, go up to the VPL where they synapse again, and then go to the parietal lobe and go to area 312. So just remember, parietal lobe is sensory, frontal lobe is motor. Lesions above the medulla will cause contralateral deficits, below the medulla, ipsilateral deficits. Okay. Spinothalamic is pain and temperature. They pretty much always will use pinprick when talking about pain. Comes to the dorsal root, again, because it's sensory. This one immediately decussates, so it crosses the spinal cord, which is why it gets affected by all these syndromes that go in the middle of the spinal cord. Ascend, VPL, parietal lobe. It goes the same 312 post-central gyrus. So at that spinal level, you can get ipsilateral or bilateral deficits. Anything else is going to give you contralateral deficits, including in the brainstem. Okay, and then you do need to know the intramedullary versus extramedullary lesions. I would say the biggest thing here is the sacral sparing. So extramedullary just means it's something pressing on the outside of the spinal cord. Intramedullary means it's something inside the spinal cord. And I'll show you in a second why you get the sacral sparing. Okay. Corticospinal does strength and movement, and you can remember that this is the one that starts in the brain and goes down because it's literally called cortex, spinal, so it goes cortex to spine. That can also help you remember if you like have a brain fart in the middle of the exam that it does movement, because all the other ones go body to brain. This one goes brain to body. So motor cortex, so it starts in the frontal lobe, area 4, the precentral gyrus. Thalamus, cerebral peduncles. This one also decussates in the cerebellar pyramids. Oh, the medulla descends and synapses and leaves the ventral horn. So remember the other ones are dorsal, this is ventral. Above the medulla, contralateral, below ipsilateral. So upper motor neuron is from the brain to the level where it leaves. Lower motor neuron is the neuron that connects the spinal cord to the muscle. So you can't have a lower motor neuron problem like within the spinal cord unless it's like right at the edge there. Anything above that level is going to be upper motor neuron. So the important things that you need to know to differentiate upper motor neuron and lower motor neuron, the biggest one is going to be like the obvious thing for you is the reflexes. So if you remember, a reflex works because it goes from the muscle to the spinal cord back out to the muscle, right? It never has to go to the brain. It's like the definition of a muscle stretch reflex. So it makes sense that if you lose the lower motor neuron, which is the nerve that connects that, then you lose the reflex. If you lose the upper motor neuron, then now the upper motor neuron doesn't send any inhibitory signals, because nerves send excitatory and inhibitory, right? So the reflex can just like do whatever it wants. So if you lose upper motor neuron, then the lower motor neuron has like super strong reflexes and is super, super hyper-reflexic. Other thing, pathological reflexes, again, it's like extra reflexes, it's great. So Babinski, you get the pathological reflexes if you lose the upper motor neuron. Because lower motor neurons do reflexes. So if you have reflexes, you have a functional lower motor neuron. And then just that weakness with relative atrophy versus atrophy with mild weakness. I always forget those. Okay. Ventral motor, dorsal sensory, talked about that. Frontal motor, parietal sensory. So yeah, extramedullary lesions are pressed from the outside. So this is where you need to know like roughly where the different tracts are. So spinal thalamic tract is here, and this is the way it's organized. So the sacral things are on the outside, which is why if you have a lesion that pushes here, it will affect the sacrum, versus you have lesions in here that are pushing out, the sacrum is like the last area that's affected, which is why intramedullary, you have sacral sparing. And then, so corticospinal is over here. We already talked about dorsal column. But you do need to know like roughly where the different tracts run. Okay, here you go. Okay. So, we know that this is almost definitely going to be somewhere in the spinal cord, right? Because why would anything in the brain give you like a sensory level here? Like theoretically could, but it's probably going to be a spinal cord thing. The other way that you know that this is probably spinal cord is because he has motor and sensory, and they both kind of start around the same spot, which tells you it's probably a spinal level. Posterior columns, no. Posterior column is dorsal column, which is vibration and proprioception. That would not cause the fecal incontinence, bladder incontinence, the paraplegia, absent sensation. It wouldn't cause any of that. So really, all you're asking is whether it's upper or lower thoracic spinal cord. The nipples are upper thoracic. Nipple is T4, so that'd be upper thoracic.
Jacq, can you go to the last slide, please? So the corticospinal tract, I know that we also find it ventrally as well. So is that just
There are like two parts of it. This is just where the main biggest part of it is.
Okay.
All right, so all the syndromes. So anterior spinal artery, also called anterior cord syndrome, infarction of the anterior 2/3 of the spinal cord. The way this is almost always going to be asked of you is you're going to hear that it's an old guy who came in with an aortic dissection, it was surgically repaired, and then suddenly he couldn't feel his legs. That's because it's supplied, the anterior spinal artery is supplied by branches off of the aorta. So it's usually T4 to T8. I didn't think this was an important thing, but apparently this is like a keyword. The anterior medullary artery of Adamowicz, something like that. Which, to me, the important thing is to know that it comes from the aorta, but apparently that's a step buzzword, I was told the other day. So symptoms. Anterior spinal artery supplies everything except for the dorsal column, so you're going to lose everything except the dorsal columns. So you bilaterally lose the spinothalamic tract, you bilaterally lose the corticospinal tract, and it's upper motor neuron problems, but you keep the dorsal column, so you keep fine touch, proprioception, and vibration. Syringomyelia, or a syrinx. Gruner referred to this as central cord syndrome. It's an abnormal collection of fluid within the spinal cord parenchyma, causing a central cavitation. So that's what this is. It can be asymptomatic. It can also cause a suspended loss of pain and temperature with sparing of fine touch and position sense. It was called the cape-like distribution. So the reason, and this is a clinical picture you really need to be able to recognize. We talked about how the spinothalamic tract comes in, immediately crosses, and so this thing here hits those crossing fibers. And so you'll lose the spinothalamic tract, just the fibers that cross right there. So if it happens right at this level, then it's just like these fibers that are crossing right there. So I'll lose sensation just in this one band. But sometimes that syrinx can be more than one vertebral level tall. So let's say the syrinx is 4 vertebral levels tall, then I lose sensation across all 4 of those vertebral levels. So the height of the syrinx is going to determine the height of the sensation loss. And this is called suspended or cape-like sensation loss. But anytime you see like a suspended sensation loss, especially when it's just spinothalamic tract, it's probably going to be a syrinx. So that's what the vertical expansion does. It changes how much sensation loss you get. Horizontal changes how many other spinal tracts are involved. So you can get muscle atrophy and weakness due to damage of the lower motor neuron in the anterior horn, if that gets affected. You can also get Horner syndrome. It has to be like kind of higher up to where the spinal cord has the sympathetic chain in it. But this little notch here is the sympathetic horn. And so that's where the sympathetics run. So if it expands to that, then you can get Horner syndrome from it. So the way that you would probably get asked that is they would give you the clinical picture and they would say, like, if this expands, what would you expect to be affected next? And Pathoma does a pretty good job of like going through that stepwise. It's diagnosed via MRI, so it's this. It's this like brightness in the middle of the spinal cord.
But they would have to tell us that in the thoracic.
Okay.
What? They would have to tell us that we were in the thoracic region for them to say, like, if it was, because we won't have the lateral horn anywhere else.
Yeah. Yes.
Back to the anterior cord, is there something to the upper motor neuron? Lower motor neuron weaknesses too? Like right where the syndrome is occurring?
Yeah. Yeah, it could be. This is, I mean, summarizing here is like the textbook presentation of stuff, right? They're not going to test you on like atypical presentations. Okay, tabes dorsalis. It's usually caused by tertiary syphilis. Slow demyelination over many years of the dorsal column. It's called dorsalis. All it affects is the dorsal column. It's pretty straightforward. So you get radicular pain. Radicular means that it's caused by inflammation at the nerve root, and so it's usually like a lightning pain. And then you get progressive sensory ataxia, and so what that means is like the position sense of your feet. You can't tell where your feet are, and so what you do is since you can't proprioceptively tell, you lift it really high and then you smack it down to try to cause pain in your foot so that you can feel the pain of where your foot is. So you're trying to use a different tract to feel where your foot is. And then Charcot joints are just an associated thing, severe traumatic injury and deformation of ankle joints. So if they show you a picture of like a weird messed up ankle joint, they're probably getting at this. Physical exam, absent that sensory deep tendon reflexes. And then this is where you get the prostitute's pupil, so the Argyle Robertson pupil, which it's sad, but it's kind of easy to remember that goes along with syphilis. And then you get the positive Romberg, which is where you stand like this, you close your eyes, trying to fall over because Romberg is proprioception. The strength is spared. Okay. Brown-Séquard, you definitely need to know this. I guarantee there will be a question on this. Spinal cord hemisection. So it's a lesion that affects an entire one side of the spinal cord. It can be caused by trauma if you get like a crush injury. It can also be a tumor or an abscess. So it's going to affect all of these tracts, right? So it's going to affect the dorsal column here. So it affects the cuneus and the gracilis. Sorry. So you're going to lose the tactile vibration and proprioception ipsilaterally, right? Because the dorsal column, we're below where it crossed up here. And then you're going to get the upper motor neuron weakness, so you're going to lose the corticospinal tract again ipsilaterally. So you get upper motor neuron signs. And then you get spinal thalamic tract, but remember, this crosses immediately, and so you're going to lose that contralaterally because all the fibers that came into the spinal cord below this level crossed as soon as they came in. So if this is the level we lose it at, let's say this is my spinal cord, we have hemisection on this side. The fibers that came in here came in, crossed, and are coming up. And some here came in, crossed, came up. So all of those are running through this side of the spinal cord. So when we mess up this side, we mess up feeling contralaterally below that. Okay, so ipsilateral upper motor neuron signs below the level of the lesion, ipsilateral loss of dorsal column, contralateral pain and temperature loss below the lesion, ipsilateral loss of all sensation at the level of the lesion, because at that level, the spinal thalamic tract hasn't crossed yet. So it comes in, immediately gets messed up, doesn't have a chance to cross. And then ipsilateral lower motor neuron signs, again, at the level of the lesion, because we're going to affect the anterior horn. Okay. And then you can get Horner syndrome. Again, it has to be at the level where you have the sympathetic chain. Okay, subacute combined degeneration. So that's degeneration. It's usually due to some deficiency. The classic ones you're going to get are vitamin B12 or E. It can also happen with copper deficiency, HIV, substance abuse, infection, chemo, vascular problems. So it's a demyelination of, so you can use the mnemonic SCD. So subacute combined degeneration, S for spinocerebellar, not for spinothalamic tract. Does not affect the spinothalamic tract. So S for spinocerebellar, D for dorsal column, and then lateral corticospinal, C for corticospinal. So you're losing dorsal column, you're losing corticospinal, you do not lose spinothalamic. So you lose vibration sense, tactile discrimination, proprioception, and that's going to lead to ataxia. Over time, you get weakness, spasticity, and hyperreflexia from the corticospinal tract loss. Again, spinothalamic totally fine. The way to tell between vitamin B12 versus vitamin E deficiency, vitamin B12, as you guys remember from last semester, causes macrocytic anemia. E will cause hemolytic anemia. All right, use this. classic tabes dorsalis. Okay, so low motor neuron disease, the two big ones are poliomyelitis and Werdnig-Hoffmann. Werdnig-Hoffmann is the floppy baby. So it's destruction of anterior horns. It's going to cause flaccid paralysis, so muscle weakness, fasciculations, hyporeflexia, hypotonia for the babies. So for the babies, it's autosomal recessive, floppy baby, and they usually die from the first year. Polio, we're going to go over later, so I'm going to stop that. Okay, ALS is, so the way you're going to recognize ALS is it's going to be a mix of upper and lower motor neuron signs. It's going to be progressive, and then for some reason they always talk about tongue fasciculations. No idea why. Every ALS question has tongue fasciculations. So it's going to start as like numbness or weakness in like one hand, and then it'll progress to the legs, the other hand. So it's going to be progressive, and it's going to be a mix of upper motor neuron and lower motor neuron signs. I'm not going to go over that because you need to know upper motor neuron and lower motor neuron signs. So atrophy of hands is an early sign. The one thing that another thing distinguishes it is there's no sensory problems. It's a pure motor problem. It's usually in middle-aged adults. It can also sometimes be seen along with frontotemporal dementia. It is fatal. I think it's 100% at 10 years. Most people die within 5 years, and they die of respiratory failure. The treatment, this is also called Lou Gehrig's disease, because this is what Lou Gehrig had. And so the memory trick for remembering riluzole, which slows progression, is Rilu, for Lou Gehrig's. Okay, all right. So neuropathies, myopathies, motor neuron disease. So a mononeuropathy is a single major nerve damage. And you will get deficits related to its distribution, usually from trauma or compression. So examples of this, carpal tunnel syndrome is compression of the median nerve within the carpal tunnel. To sensory loss, then motor, and so that's going to be, I'm sure you guys remember, median is these three. Ulnar neuropathy is from like sitting like this for a long time. And so that's going to be here, ulnar nerve. That's scary. Hi, Erin. Oh, thank you. So median nerve is also increased in pregnant women. I had a patient who was like a 70-year-old lady, and she was talking about tingling here, and I asked her if she types a lot, and she was like, oh yeah, I do, I type a lot. And I was like, oh, okay. She was, every time that I go to the library to check my email, I always type. I was like, you're the cutest person I've ever seen. Okay, so ulnar mononeuropathy is here, this side of the hand, I'm sure you guys all remember. Peroneal, injury to the lateral knee, so it's like football injuries, and it leads to foot drop. Radial, so there are two ways that you will get asked about radial neuropathy. One is going to be the person who got drunk and fell asleep in a chair, and what happens is if I'm sitting in the back of the chair and you put your arm over it, and you have that pressure in your armpit all night, that will do it. The other way is crutches that aren't fit well. So it's constant pressure in your armpit messes up the radial nerve. And I'm sure you guys remember that radial nerve does all the extensors, so if you lose it, you get the wrist drop. You can't extend your wrist. Okay, diagnosed clinically or with EMG. Treatment is relieve the compression. Okay, super important to be able to localize deficits because this is not something that you can really guess. So you just have to memorize this. So some of the reflexes, these are the the first aid mnemonics. 1, 2, buckle my shoe. So S1, S2 is your Achilles. 3, 4, shut the door. L3, L4 is your patellar reflex. You're kicking the door shut. 5, 6, pick up sticks. So pick them up like this. Brachioradialis, biceps. Both of those are by 5 and 6. So it's this. And then 7, 8, lay them straight. So to extend your arm, triceps reflex, C7, C8. This is a really gross one. 3, 4, winks galore. S3, S4 is the anal wink reflex. And that will show up in questions surprisingly often. It's gross, I know. All right, so you also need to know sensory dermatomes. So because of the way your arms rotate when you're developing, the dermatomes are kind of weird. So you gotta like hold your arms out straight like this with your thumbs up, and you get C4, C5. You need to know that thumb is C6, C7, C8 does all the way like to here, and then it goes T1. So it's with your palms facing straight forward, and then it goes out and loops back this way. Important ones to remember, C6, C7, C8. The thumb is the one that's like the easiest for them to tell you. Because they can't tell you like they lost sensation on their forearm, right? Because that could be like C4, C5, C8, whatever. But if they tell you thumb, it's C6. And you should try to associate that with the reflex. So especially if they tell you that there's no bicep reflex and they can't feel their thumb, you know it's a C6 problem. Some other landmarks that you need to know, nipples are T4, umbilicus is T10. Okay, and then the legs, you need to be able to do L4 versus L5 versus S1. And the reason is because that's where you get slipped discs a lot of the time. And so they're going to give you the loss, and they're going to ask you where the disc is. So L4, so with the legs, they all rotate in. So L4 starts out here. The important thing to know is that it goes over the front of your knee. And the way you can remember that is that L4 also does sensation to the patella, right? Or sorry, does the patellar reflex. So it starts here, goes over the front of your knee, and then goes to the inside. So it does your medial calves. And it'll do your medial malleolus. L5 starts on the back, kind of goes down the back, and it'll come in below the knees. So it does the front of your calf, and then it also will do the tops of your feet, your big toe, and your big toe is the one that's remembered, and then muscle-wise, it does dorsiflexion of your feet. So it does the top of your feet sensory, and then it also moves the top of your feet towards you. So those are kind of connected, so that makes sense. S1 is going to do the butt, the back of your legs, it's going to be your lateral calf, and then it's going to do the very lateral edge of your foot, and also the bottom of your foot, and then it also does plantar flexion. So it does the bottom of your foot, and it bends your foot down. And S1 also is the Achilles reflex. So the way that they'll ask this question is they'll tell you the Achilles reflex is gone, they'll tell you they don't have sensation on the outside of their foot, and they might tell you they don't have sensation at the bottom of their feet. Or they'll tell you they have shooting pain that goes from their butt down the back of their legs. So one thing that's important to know is that, so like I said, this is where you're going to get a lot of those slip discs. And they'll tell you, like, they have a slip disc between L4 and L5, and you need to know that that affects L5. So it affects the lower of the two. The reason, I really like this illustration. So if this is the disc, right? So if this is L4, this is L5, L4 leaves before, and so the disc is actually pressing right here because at that point L5 is the nerve root that's the closest to the outside because it's the one that's about to leave. So you just need to know that it affects the lower of the two. Are there any questions on that?
The herniation, that's the word.
Yep, so if it's the disc between L4 and L5, it's going to affect the L5 nerve root.
Yep.
Okay, any other questions?
And that's different when we're in the cervical branches, right? Because they don't leave.
Cervical, yeah. Because cervical, they leave above.
Okay.
I don't think you really get a whole lot of slip discs there. Generally, if you're talking about a slip disc, you're going to be asked to differentiate between L4, L5, S1, and you're going to need to know whether a disc affects the nerve root above it or below it, and it's below it for those. Okay, so polymyositis, dermatomyositis, you guys are going to learn about in the next unit, but basically, you know what itis means, it's inflammation. Poly meaning many, myo meaning muscle. Polymyositis is inflammation of many muscles. Dermatomyositis is polymyositis plus skin problems. I think the important thing to know about this is that it's immune mediated in the US. So it's usually either an autoimmune problem or it's a malignant, or it's a malignancy. You know the things associated with cancer? Those. Okay. Polyneuropathy is also what's called peripheral neuropathy, disorder of multiple major small nerves. I don't know why it says major. Multiple small nerves. So for neuropathies, you usually lose sensory first. And for polyneuropathy, which you can kind of think of as, the example that I think of is diabetic neuropathy, because we all know that they lose sensation in their feet, right? So polyneuropathy, you have stocking glove distribution, which makes sense because those are the longest nerves. So if you're going to have a nerve that's messed up, the longest ones make sense to get hurt. Yeah. Distal limb weakness and atrophy, early loss of muscle stretch reflexes. Okay. So the big example of this is Guillain-Barré. So it's an ascending, areflexic acute polyneuropathy. So the classic textbook example is they get weakness starting in their feet and it gradually moves up. They do not lose any sensory, so they can feel everything. They get weakness and areflexia. It's an autoimmune condition, so it's usually post-infectious. So in the question, it'll say that they had a cold a month ago or that they had food poisoning a month ago. Diagnosis, they'll have what's called cytoalbuminologic dissociation, meaning they have an increased protein amount in their CSF, but everything else is fine. And you can do EMG testing for demyelination, and you give them plasmapheresis, you give them plasmapheresis or IVIG, and then they usually recover just fine. The only thing is they just need to be kept in the hospital because they can end up with weakness of the respiratory muscles, and that can kill them. But if you get them past that, then they'll be fine. Yeah, Dan.
So the polyneuropathy, we should not assume that that's central. That's just saying that their muscles are not able to move? Or that they would...
Yeah, so it's nerves, right? So nerves can be motor or sensory. So any type of nerve problem. So polyneuropathy, there are lots of different types of polyneuropathy. So you can have motor polyneuropathies and you can have sensory polyneuropathies.
And so Guillain-Barré is a motor?
Yes.
Okay.
Yeah. Okay. Some hereditary neuropathies, they usually cause demyelination, axonal loss, or abnormal interactions between molecules and axons. They're going to onset in childhood. You'll have these orthotic deformities, so scoliosis, or this is a hammer toe, this is pes cavus. The biggest one you're going to see is Charcot-Marie tooth. I didn't get the sense from Dr. Granger's lecture that he was really going to emphasize this, but CMT1, Charcot-Marie tooth 1 is the thing. Okay, so myopathies are diseases of muscles. So first you're going to get the weakness and atrophy, and then eventually you lose reflexes. So you can contrast that to neuropathies, where you lose the reflexes, which are more of a nerve thing, right? And then you later get weakness. And again, you have intact sensation with myopathies because the problem is with the muscle, it's not with the nerve.
Can you repeat that again, Jackie?
Yeah, so with neuropathies, you lose reflexes fairly early because reflexes are carried by nerves, right? With myopathies, you get weakness early because the problem with the muscle, but your reflexes stay fine for a while because reflexes are mediated by nerves, and this is not a nerve problem, it's a muscle problem. And then your sensation is also intact with myopathies because, again, that is carried by nerves, and this is not a nerve problem. The most important hereditary myopathy to know is Duchenne's muscular dystrophy, really highly tested, X-linked, and it's a problem where they don't have any dystrophin. So the muscles degrade. The way you're going to recognize this on a test is you're going to have what's called calf pseudohypertrophy. So they're going to be like, this boy was really thin, but he had super muscular calves. It's not muscle, it's like fat deposition. And then Gaucher's sign is what it's called. No, Grauer's. I don't know what that's called. Okay, you guys know. But they're going to describe it needing to use their hands to push off their legs to stand up. And they usually die in their teens from hypertrophic cardiomyopathy. Diagnosis, family history, elevated serum CK. Okay, so you have to be able to differentiate myasthenia gravis from Lambert-Eaton syndrome. So myasthenia gravis is a postsynaptic problem. It is an autoantibody against the postsynaptic acetylcholine receptors, and it's not an activating antibody, it just blocks it. Sorry. So what you're going to get is you're going to get weakness that gets worse the more you use the muscle. The reason being, if your muscle is rested, then there's a lot of acetylcholine built up at the presynaptic terminal, and so when you send that first signal, you're going to get a ton of acetylcholine release, and some of it's going to be able to outcompete those antibodies. Then the more you use that muscle, the less extra acetylcholine there is, and so it gets worse at outcompeting the antibodies, and so the antibodies affect it more, and you get worse weakness. So the way it's described is fatigable. The most common initial symptoms are ptosis, diplopia, and blurred vision, just because you use your eyes a lot, and so those can get fatigued easily. So there are two types, ocular, where those are the only symptoms, or generalized. The other symptoms that you hear a lot about are like difficulty swallowing, stuff like that. They're associated with the thymoma, or thymic hyperplasia, And so this is gonna be like a weird question. I don't know if they'll ask you this on your exam, but definitely for step 1 you have to know that if somebody presents with these symptoms, the first thing you have to do is get a chest x-ray, which is like not what you would expect if someone comes in with like diplopia. The other way you can diagnose it is with the acetylcholinesterase inhibitors. So it's called the edrophonium test, and that will like acutely reverse the symptoms. Because when you get rid of acetylcholinesterase, you increase the amount of acetylcholine in the synapse, and then it can outcompete the antibodies again. You also, the way they actually diagnose it in the real world is they test serum antibodies to acetylcholine receptors or the musculoskeletal antibodies, or sorry, the musculoskeletal antibodies. Treatment, the main one here is going to be pyridostigmine, but any acetylcholinesterase inhibitors. You can also give steroids and immunosuppressants. If they're in what's called myasthenic crisis, which is like a acute worsening of their myasthenia, they can have respiratory failure because the breathing muscles can be affected. And so you need to intubate them and then give them either plasmapheresis or IVIG. So plasmapheresis is where they take your plasma and they filter out all of these antibodies. Okay, so you need to know that that is a postsynaptic problem. It is the postsynaptic receptors that are getting blocked. So the contrast to that is a presynaptic problem, which is Lambert-Eaton myasthenic syndrome. So this is an autoantibody against the presynaptic voltage-gated calcium channels. And so it again is not an activating antibody, it's a blocking antibody. And so when it binds those, it can't release the calcium. So you get proximal muscle weakness. The other thing that you can use to differentiate between Lambert-Eaton and myasthenia is that Lambert-Eaton has autonomic symptoms. So you get dry mouth and impotence. And also, the big thing is myasthenia gravis gets worse with muscle use. Lambert-Eaton improves with muscle use. So it's like the more times you try to get that calcium to release, the more calcium kind of builds up behind the channel, right? And so then you can overcome it. So it gets better with more muscle use. And this is a paraneoplastic syndrome, and it's mostly connected with small cell lung cancer. So you guys actually learned this term last semester. When we talked about small cell lung cancer, you should know what it was. And so you again need to look at the chest and you need to see if people have lung cancer, especially if in the questions then they're like, this person has a 55-year smoking history. Okay. And another way that they could tell you about this is that for myasthenia gravis, they're going to talk about a decremental response to repetitive nerve stimulation. So they might show you a nerve stimulation and the response will get shorter, like bar showing the strength of the response, versus because it gets worse with use, versus Lambert-Eaton, which gets better with use, and it's an incremental response. So every time you stimulate it, the response gets larger and larger. The acetylcholinesterase inhibitors, so like the edrophonium test, doesn't help the symptoms at all with Lambert-Eaton. So the treatment is usually immunosuppressants, where you can do this 3,4-diaminopyridine. Botulism is also presynaptic, but we're going to talk about it later. I don't want to take up time with it. Okay, this is a bad question because there should not have been numbness. Because this is supposed to be Guillain-Barré, but Guillain-Barré does not have numbness, so I didn't write this question, sorry, I should have vetted it better. But ascending paralysis, you had a upper respiratory tract infection 4 weeks ago. He has ascending paralysis and hyporeflexia, or he actually has areflexia. They say the sensory examination is unremarkable, but he shouldn't have had numbness in his toes and fingers. The other thing to note here, elevated protein. So again, for Guillain-Barré, for the CSF, you get an isolated elevated protein, and it's treated with IVIG. Okay, so, sorry, I don't want to keep you guys forever, you're like falling asleep. So double vision usually happens at the end of the day. So once she's been using her eyes for a while, her eyes get tired and they don't work anymore. Jaw cramps while she's eating steak, so eating something that's really chewy takes a lot of chewing. funny change in her voice after talking for a while. So you can also get dysphonia, where the muscles that make your voice, I don't know if it's like the ones that control the vocal cords or what, but the muscles get tired. Normal reflexes, no sensory loss, normal other levels of stuff. So which of the following is most likely to be abnormal? So again, this is one of those two-step questions. So what does she have? She has myasthenia gravis. And what's often associated with myasthenia gravis? Thymoma. Okay, so we want to get a CT scan of the chest. Okay, increasing 6-year-old boy. So we're thinking pediatric problems. Increasing weakness, no significant medical history, just typical coughs and colds, stomach flu last month. They told you he had stomach flu last month, they're probably getting at something that's post-infectious. Otherwise, who cares? Parents are not concerned as they know that their son appears muscular to them, noting his large calves. Okay, so you watch the boy play, see that when he needs to stand up, he uses his arms to push off his legs in order to stand. What's the boy's prognosis and what else is true about his condition? So this is not post-infectious, but that part of the question would be trying to lead you to something like Guillain-Barré or something. What does he have? Duchenne's muscular dystrophy. What's the prognosis for that?
C.
Yeah, he's going to die of, hypertrophic cardiomyopathy.
There's no way to slow this down?
There are a lot of experimental trials with Duchenne's right now, but as far as I know, there's definitely no way to stop it. I don't know if they can give dystrophin to try to help some of the symptoms. I don't know, but for now, it's definitely fatal, like within the teens. Okay, so we got through all the big sections except for stroke. Do you guys want to take a break or no?
No.
Okay, cool. All right, so for migraines, the two biggest things you need to know is this unilateral or bilateral, and what is the sensation of it? For headaches, for all of them. So migraines are pretty much always unilateral. They are described as pulsatile or throbbing. Something that Dr. McCoy emphasized in his lecture is that the pain is caused by the trigeminal nerve and its release of like the neuropeptides. It's usually in reproductive aged women. There is a prodrome or an aura. You can have photophobia, phonophobia, nausea, vomiting, you have all kinds of things. You can have a postdrome. Treatment is going to be triptans or NSAIDs, so NSAIDs are first line. Preventative, topiramate is often used. You can also use Botox, TCAs. You can also use triptans, I believe. Okay, cluster headache. Okay. Unilateral, so again, bilateral, unilateral. These are going to be unilateral, periorbital. They're going to be described as feeling like someone stabbed an ice pick through their eye. So they don't last very long, but what happens is they have them every day for like a month, and then they go away. And then the next year, usually in the same season, they have them every day for a month, they go away. These are pretty much always going to be in men, red, watery eyes, runny nose, and they also get Horner syndrome when they have the headache. They can. The treatment is going to be inhaled oxygen, injectable triptans, or intranasal lidocaine. Okay, tension headaches, the only one of these that is bilateral, well actually, sorry, the next one's bilateral too. The only one of the chronic headaches that's bilateral, they're going to describe it as band-like or pressure. Usually lasts 4 to 6 hours. Treatment, water, no stress NSAIDs. These are just like the headaches that everybody gets occasionally. Some people just get them more often. And the thing you need to be able to recognize is pseudotumor cerebri, also called idiopathic intracranial hypertension. This is going to be a young, overweight woman. So it's going to be a woman in her 20s or 30s. They're going to tell you what her BMI is. They're going to tell you she came in with a terrible headache and may or may not have visual changes also. So the opening pressure on her CSF is going to be at least 250 millimeters of water, but the contents of her CSF is going to be normal. Treatment for this is lower the CSF level. So you can do that via acetazolamide, via topiramate, or the lumbar puncture is actually both diagnostic and therapeutic. That will relieve the pain for a little while, but you need to do something else like these diuretics. The long-term treatment is weight loss. Oh. You are so smart. So the other thing for this, I thought it was going to come up, is that because of the increased intercerebral pressure, their optic discs will blur. So if they show you like a fundoscopic picture or tell you the optic discs are blurred, you should think pseudotumor cerebri. So this is not pseudotumor cerebri. New onset headache, unilateral, throbbing, bright spots in her vision. This is a migraine. Okay, MS. So it happens in white women who grew up in cold areas. It is associated with EBV and also with canine distemper virus. And it is also associated with being born in, I think, March or October, weirdly. Pathogenesis, it's an autoimmune, so environmental triggers plus susceptibility cause autoimmune demyelination. The big thing for this is you have the lesion separated by time and space. So you have to have evidence that it happened at more than one occasion and they were at different things. So the way that this question is always going to be asked is it's going to give you some clinical situation and it's to say, like, by the way, 4 years ago this person lost feeling in their leg for a month and then they were fine. So some of the common conditions due to common locations of the lesions are optic neuritis, which is going to be blurred vision in one eye, pain with eye movement, and can have red-green color blindness. It's going to be sudden onset. Vertigo and scanning speech, internuclear ophthalmoplegia, which is what we talked about before. You can get hemiparesis or unilateral loss of sensation, lower extremity loss of sensation or weakness, and bowel, bladder, and sexual dysfunction are also fairly common. Again, remember we said trigeminal neuralgia for the young person, you think MS, and then you can also get ataxia or an intention tremor. That's a really... the symptoms get worse with heat, so they actually used to test for MS by having somebody sit in, like 50 years ago, by having somebody sit in a warm bathtub and see if their symptoms got worse. Yeah, okay, so another like buzzword you need to know for this is Lermit-sign, which is an electric shock sensation. So if you do that and bend their neck, they're going to get like a shock sensation down their spine, and that's pretty pathognomonic of MS. Okay, so disseminated time and space, something that McCoy really emphasized is that it can be diagnosed off of a single MRI. MRI, you're going to see periventricular plaque, so Dawson's fingers is a really common presentation, which is the thing he showed you, where if you look at it this way, we have the ventricle here, you're going to see the plaques going up perpendicular from the ventricles. Lumbar puncture is going to show oligoclonal IgG bands and myelin basic protein, which is the product of the degradation of the myelin. The acute treatment, or the treatment for acute flares, is high-dose IV steroids. And you need to know that it is high dose and that it is IV. Because oral, just like you're not going to get enough of them. Chronic treatment, beta interferon and natalizumab. The important thing about natalizumab is that it increases incidence of, PML. So it was taken off the market for a while, but it's back. And then treat symptoms. Okay, differential diagnosis. Neuromyelitis optica is a longitudinally extensive spinal cord lesion. So this is a big old lesion here. It can cause bilateral optic neuritis, and you test for it by looking at the NMO IgG antibody. And then acute disseminated encephalomyelitis causes these fluffy multifocal lesions. So these ones that kind of look like clouds. It's post-infectious, and it can cause headache, vomiting, drowsiness, meningism, which just means symptoms that look like meningitis. And it's more common in kids than adults. And then PML, which is a reactivation of the JC virus, and it's increased by natalizumab, and we will talk about it later. All right, cerebellum, basal ganglia. So if you have a problem with cerebellum, basal ganglia, you have movement disorders. So cerebellar anatomy, basic stuff, causes ipsilateral deficits because the cerebellum is like double crosses. So it goes brain, crosses the cerebellum, crosses back to the body or whatever. So hemispheres are going to cause tremors, dysmetria, dysdiadochokinesia, and so it's going to cause problems in the limbs, basically. Vermis syndromes are going to cause truncal ataxia and postural impairment, gait ataxia. If you are falling from a cerebellum problem, you fall towards the side of the damage. So if you fall to the right, it's because your right cerebellum is messed up. Alcohol messes with the cerebellum, so it causes atrophy of the anterior superior vermis. So it's up here, and this doesn't show it, but the feet actually come together and touch at the tip right here. And that's why you get the gait ataxia. You also get like central, and that's why you get the lower limb dysmetria. Okay.
Question.
Yeah.
Do you have any tips for homuncular, or is this just treatment medication?
mean, this one's like fairly straight. I don't think you need to remember the details. I think you just remember that like the vermis is the central part of the cerebellum, right? And so it causes problems in the central part of the body. Hemispheres cause problems on the more lateral parts of the body.
Not just for the cerebellum, but maybe for the spinal cord as well, and like up the.
So for the hemispheres, this is so silly. The way I remember it, if you look at the homunculus for the hemispheres, you only kind of need to know like generally where stuff is, because basically what they're going to ask you is this MCA territory or is this ACA territory? They're not going to be like, what is like the very exact minute location? The way I think about it is, you know how in elementary school sometimes you would hang on the monkey bars upside down, if you were fun, and the monkey bar would be like right here behind your feet, right? So the way I think about it is, this is so stupid. I picture the edge of the brain going into the corpus callosum as like the monkey bar, and so the feet and from the knees down hangs into the area between the two hemispheres, and then the body lies back like this along the outside of the cortex. So if this is where the two hemispheres meet, so this is like corpus callosum, you're gonna have foot, leg, knee, top of the leg, and then the body hangs back like this. So the face and the arms and the chest are back here. I just think of that. It works for me. I don't know if it'll work for you guys. Okay, so know the basic order of the deep nuclei. That's Dr. D's thing was the fat guys eat donuts. On Dr. Greener's slides, he had the globose emboliform nucleus labeled as interposed, which is another name for it. But medial to lateral is fat guys eat donuts or just FID. Okay. What? There you go. All right, so for the cerebellum, the things that I would recommend you definitely know from Dr. Greener's lecture are, he really emphasized for the three peduncles what goes into each peduncle and what goes out of each peduncle. So it makes sense that the stuff from the spinal cord is going to go into the inferior cerebellar peduncle, right, because it's the closest. You need to know that middle cerebellar goes to the cerebral cortex, or gets stuff from the cerebral cortex. And then I would also definitely know that middle cerebellar has no efferents, and that the superior, I would know this whole table, honestly. But these two, I think, are the most important boxes. And this is another thing that he spent a lot of time on. Okay, so number one, Purkinje cells are the only axons that leave the cerebellar cortex. Yeah, okay. And then you need to know the difference between the climbing fibers and the mossy fibers. So climbing fibers are here. So they come from the inferior olive, and then they go up, and they only interact with a single Purkinje cell, but they interact with that one Purkinje cell hundreds of thousands of times. So one climbing fiber has a really strong, really big impact on one Purkinje cell, but it doesn't have an impact with any other Purkinje cells. And you need to be able to contrast that to mossy fibers, which have very small interactions with hundreds to thousands of different Purkinje cells. So they have a very small impact on a lot of different Purkinje cells. So you need to know which one is 1 to 1 and which one is 1 to 1,000.
Wait, does it go on the Purkinje or does it go on the granule cell?
It goes to the granule, which then sends the parallel fiber.
Okay.
Mossy fiber's right here. Goes up here, synapse on the granule cell, that sends the parallel fiber. Parallel fiber goes up here, interacts with hundreds of thousands of cells. But he kind of talked about them as mossy fiber versus climbing fiber, if I recall correctly. Okay, so you need to know gates, okay? So this is the white-based cerebellar gate. Okay, what's this gate called when they do this? This is like post-stroke. Paretic gate is what it's called. Okay, toe drop. Okay, this is the scissoring gate. And so the scissors gate is, what's happening is that these muscles are really tight, the muscles that pull in, and so it happens from muscle weakness. So like MS patients have this a lot, and it's just, so it's a muscular problem, like a core muscle problem. Okay, this is like the slow shuffling gait. So when you see this using Parkinson's, okay, so yeah, there you go. Yeah, so the broad-based gait is going to be a cerebellar problem or a dorsal column problem. Hemiplegic gait is from stroke. Tibetic gait, which is foot flap, is from tabes dorsalis or severe neuropathy. Steppage gait, which is the foot drop, which is where you do that because the toe drop because you don't want to drag your toe, is peroneal nerve lesions. The waddling gait is myopathy. That's the name for it. Scissors gait, again, MS, cerebral palsy. It's from the spastic paraparesis, and then Parkinson's gait, which is slow and shuffling. All right, so some of the signs of cerebellar dysfunction: dysmetria, which is where you overshoot or undershoot an object, because so the cerebellar kind of does two different things. Well, it does several things. It does balance, but it also does, it corrects movement as we do it. So if I'm trying to like reach for that thing, when I first start reaching towards it, my trajectory might be off a little bit, and so as I reach for it, my cerebellum corrects my trajectory. But it also helps you edit movements if the thing you're reaching for is moving. Yeah, exactly. So the way that we do that test that she was just doing is, it's hard to do it on yourself, but if this is the doctor's finger, they'll hold their finger there and tell me to touch it, but what they actually do is they move it, and then I have to like predict where it's going to go, and that's your cerebellum does that. So dysmetria is you can undershoot or overshoot. Kinetic tremor is where you have a tremor. It's an intention tremor basically. You have a tremor when you're moving. So when you're doing when you have a movement of intention. Dysdiadochokinesia is this. So that's another way that you can test for cerebellar function. Rebound. This is so mean. Rebound phenomenon. So again, pretend this is someone else's hand. If they were holding like this and making me, yeah, exactly. So if someone let go of my hand, I would stop before I would hit my face. But your cerebellum is what does that. And so what you actually do is, again, I'm a patient, doctor. So the doctor holds this with one hand and the doctor puts their other hand here so they don't punch themselves in the face. And then dysarthria and nystagmus. So Aaron, what you're asking, if there's another thing to make your eyes beat, cerebellar problems can do that. So bedside test, so finger, nose, finger, heel, shin, heel, and rapid alternation, which can either be the dysdiadochokinesia, or you can have them do this, lots of different things.
Would a cerebellar problem cause nystagmus in both eyes or one eye?
Depends on which side. It depends on if you have a one-sided or two-sided cerebellar problem.
Okay.
Okay, so spinocerebellar degeneration, you can have hereditary disorders. Friedreich's ataxia is the most common. So it's a trinucleotide repeat from defect in chromosome 9. It's AAG repeat. The clinical picture, you're going to limb dysmetria, gait ataxia, dysarthria. So the way that I remembered this is like CD, it is corticospinal tract, dorsal column, deep tendon reflexes, and cerebellum. So you also get scoliosis and pes cavus, because again, a lot of the like hereditary stuff, you're going to get those, and they also die from cardiac hypertrophy at a pretty young age. Okay, so for basal ganglia, you should know roughly where each of these are. So this is a section of the brain like this. These are your ventricles up here. So you have your thalami here, caudate, putamen, GP, and then like down here somewhere would be the substantia nigra and the subthalamic nucleus. And right here, this path is the internal capsule, which is all the motor stuff. So one way that they can ask you a question is they can show you this picture, and they can either give you a clinical scenario and ask where the lesion is, or they can show you a lesion and they can ask what would the outcome of that be. Okay, so you definitely need to know this direct versus indirect pathway thing, the go, no-go pathway. So the direct pathway. When dopamine binds the direct pathway, it inhibits the globus pallidus internus, which removes inhibition from the thalamus and allows the thalamus to make the body move. So dopamine allows for the movement. In the indirect pathway, dopamine inhibits the indirect pathway, which is the no-go pathway. So in the indirect pathway, we're here. The indirect pathway inhibits the globus pallidus externus, which removes inhibition from the globus pallidus internus, which causes inhibition of the thalamus. You get no-go. So basically, you can think of dopamine as increasing movement, which is why when you have Parkinson's, which is less dopamine, right, because you lose the substantia nigra. When you lose the substantia nigra, you lose dopamine. You get the akinesia or bradykinesia, like you can't move very easily. And then you also should probably be familiar with the subthalamic nucleus. just know that it stops movement. So if you have a subthalamic nucleus activates globus pallidus internus, which is going to inhibit the thalamus. So subthalamic nucleus causes no-go. The other thing to know about the subthalamic nucleus is that damage to the subthalamic nucleus is what causes hemibolismus. You can see that here. The subthalamic nucleus is gone. So hemibolismus is described as like violent flinging motion. So what happens is the person will just be like sitting there totally normal and will just be like really violent and completely out of their control. It's not like chorioavitosis where it's kind of subtle. It's very violent flinging. So the way I remember that is subthalamic nucleus, remember like a submarine, and then hemibolismus, like ballistic missile, like submarines have ballistic missiles. And that is contralateral. Basal ganglia has contralateral problems. So normal, Parkinson's disease, again, you lose substantia nigra, so you, I think we have that on there. Nope. You lose substantia nigra, so you decrease the go pathway, increase the no-go pathway. Yeah, okay, cool. So dystonia, rapid, violent, that's not what dystonia is. That's wrong. Ignore that, that's not what dystonia is. Tic, brief, semi-purposeful, stereotype, repetitive contractions. Dystonia is where you have involuntary contraction and you just like stay there. So a really common form of it is torticollis, which is it in the neck. And so someone will just be like this and they're just stuck like that. And it's often a medication side effect, and you can also see it in people with like congenital musculoskeletal disorders.
Did you have Huntington on that last slide?
Mm-hmm.
Why is that a part of the basal ganglia?
Because it affects the caudate and putamen.
Oh, okay.
Yeah, it causes degradation of the caudate and putamen. Okay, asterixis, we talked about before in the GI is this, it's the liver problem. Postural tremor is like familial tremor. So postural is like when you're trying to hold a posture. So it's not resting tremor like you have in Parkinson's, which is where you get a tremor when you're just chilling. It's like if you're trying to like hold your, and it's not an intention tremor when you're trying to move, it's when you're trying to hold in a specific position. And you, for this essential tremor, you can also get a voice tremor, so like makes you sound like you're like a really old person. And then, so that's treated with beta blockers. And it also, the tremor improves with small amounts of alcohol, which is another way that they can have you differentiate that. And then kinetic tremor is movement tremor, or intention tremor, whatever you want to call it, is cerebellar disease. Okay, so treatments for that, you should know the Parkinson's treatments. Essential tremors, again, beta blockers, usually propranolol, hemibolismus, all that stuff is dopamine antagonists, because it's too much movement, right? And dopamine causes movement. Yeah, that's all I need to know. All right.
Question?
Yeah.
Do you want to take a break?
I mean, I don't need a break. You guys can if you want to.
You don't need a break?
Okay. All right. Neuroimaging. CT.
She's
So
a
CT
beast.
is fast, which is why it's what you do when somebody comes in and you think they may have had a stroke. It does have radiation exposure. So if you're being asked about like what you do for a kid, you don't want to give them a CT. And it does have a contrast agent. You can do CTs with or without contrast. MRI gives you way better images, but it takes a long time. So if you think someone's having a stroke or there's some like emergent situation, you don't want to give them an MRI because it takes like an hour. There's no radiation, so that's good. Different contrast agent, and then you should know the difference between like the T1 weighted and the T2 weighted. T1 highlights anatomy, CSF is dark. In T2 it highlights pathology, and CSF is bright. So T2, H2O, it's like the water that's highlighting, right? And then FLAIR also highlights liquid, but it removes CSF. I don't know how. And you should just do like a quick review of how like blood versus edema versus all that stuff look on it. I'm not gonna go through it. Okay, visual symptoms, visual system, sorry. Sorry, I don't, that's weird. Okay, sorry. Okay, all right, so that is a blurred optic disc. So you can see here, the optic disc should be nice and should have like nice boundaries, and it doesn't, it's blurred. So there's two conditions associated with that are optic neuritis, which is unilateral, and papilledema if it's bilateral. So what's the most common etiology of optic neuritis? Yeah, I think so. Sorry, it's probably in the notes. Sorry?
Your notes say MS.
Damn it, I just was thinking that. Okay, it's probably MS. Yeah, it is MS. Sorry, yes, it is MS. Especially in like the young woman. So most common etiology is going to be MS, and the presentation is that sudden onset of unilateral blindness, pain with movement, red-green color blind. Papilledema is going to be bilateral, and that's from increased ICP, and a lot of the time that is going to be from pseudotumor cerebri. The clinical presentation of that is going to be signs and symptoms of increased intracranial pressure, which is going to be things like headache, change in consciousness, vomiting, all that fun stuff. Okay, so in this one, you have a clear optic disc. There you go. So the optic disc is clear, but it's pale, it's small, atrophied. So pale optic disc, sharp, distinct margins. Okay, you need to know the names of all these refractive errors. This gives me so much pain to say this because my friend made up this joke and thought it was the most hilarious thing on earth. But, so farsightedness means that you can see far, and her joke was that optometrists are optimists, and so they name it after the thing that works well, which is like the farsighted. If it helps you remember, I hope it's helpful. I think it's stupid. And so you need to know farsightedness means that you can see far well. Light focus is too far back, and you need converging lenses. I'm not going to go through the rest of this because you just need to memorize it. There's nothing conceptual there. Okay, so this is going to be try to name what it is. Apparently I just told you the first answer. Red sclera, conjunctival swelling, itching, discharging, crusting. It's going to be pink eye, so that's that top picture. Oh, I did not animate this well. Okay, so unilateral red eye with photosensitivity, blurry vision, plus or minus hypopyon, which is this pus in there, is uveitis. And what's it associated with? What is it associated with? What's the treatment? Systemic inflammatory diseases treated with steroids. Okay, painless opacification of the lens. It has halos and glares at night. It's the cataract. And what's the important acquired risk factor? Mm-hmm. Mm-hmm. Okay, cool. So the easy way to differentiate between, actually we're going to go over this in a sec. Okay, increased intraocular pressure and progressive peripheral visual field loss. Okay, that's glaucoma. So glaucoma versus cataracts. Glaucoma, it goes from peripheral in. Cataracts, you start with blind spots in the middle and they expand. So that's like an easy way to differentiate between those two. So which is open angle or angle closure age related? That's right, it's open angle. Which one is abrupt and very painful? Angle closure. What are the other symptoms of that? Red eye, sudden vision loss, frontal headache, fixed mid-dilated pupil, and how do you treat it? Pilocarpine, and you do not give epinephrine. You really emphasize the no epi thing. Okay, treatment in general for glaucoma. It's generally getting medication. The two that were emphasized on his, so M3 agonists are often used, the muscarinic, as well as alpha 2 agonists. The two that he had highlighted on his slide were the latanoprostene, Bunon, and Tersudo. I don't know what those are. What's the leading cause of blindness worldwide? Cataracts. And then the leading cause of irreversible blindness is glaucoma. Also something he really emphasized in his lecture. Okay. Diabetic retinopathy causes a 2 to 5 times increase in cataracts, 2 times increase in glaucoma. If it's mild non-proliferative, all you get is microaneurysm. Moderate non-proliferative, it's worse than mild, but it does not reach the 4-2-1 rule, which is severe non-proliferative, which is at least 20 intraretinal hemorrhages in each of the 4 quadrants, venous beating in at least 2 quadrants, and prominent intraretinal microvascular abnormalities in at least 1 quadrant. And then compare this to proliferative, which is like a really bad one, which shows definite neovascularization or preretinal or vitreous hemorrhage. I don't think there's supposed to be a G there. Treatment, anti-VEGF, laser surgery, vitrectomy. So I believe the treatment for the non-proliferative is just controlling blood glucose. But anything that's proliferative, anti-VEGF is going to be your treatment. Okay, sudden painless complete loss of vision with cherry red spot on fovea. Central retinal artery occlusion. So you treat with arterial dilation, rebreathe CO2 or sublingual nitro. One thing I talk about is like gently massaging over the eye, over a closed eye to dislodge the embolus. And then you can also give IV acetazolamide or mannitol to control the intraocular pressure. Sudden painless loss of vision with this. I think this is like the blood and thunder thing, right? Oh, whoops. Central retinal vein occlusion, which is the blood and thunder. This is treated with anti-VEGF or dexamethasone. All right, crinkling of retinal tissue. Think. Retinal detachment is a risk factor. High myopia or history of head trauma, often preceded by a posterior vitreous detachment. And then smokestack is the key word for what? Central serous chorioretinopathy, symptoms of which blurred vision, central scotoma. So scotoma is a blind spot. Bone spicule-shaped deposits around the macula, so that's this. Retinitis pigmentosa. What type of vision do they lose first? Yeah, so like night vision and peripheral vision. He also emphasized that. And then the new drug for that was Luxturna. All right, stroke time. So a TIA is a transient ischemic attack. So it's a transient stroke. So you have a stroke, you have the symptoms from it, the symptoms go away within 24 hours. So it's reversible, focal, no change on imaging. So the pathogenesis, again, temporary obstruction. Localization, so if they have aphasia with hemiparesis, where is that going to be? So aphasia is a problem with talking. The MCA supplies all the speech centers. So that's a pretty important thing to know. Left MCA is speech. Ataxia, cerebellar artery, so it could be ska, ica, or pica. And then monocular blindness, or the lowering of a dark shade, ophthalmic artery. Okay, so for global cerebral ischemia, it means there's a decreased blood flow to the entire brain. Etiologies of this are shock, chronic hypoxia, which is because of anemia, hypoglycemia, or significant atherosclerosis. I don't know if you guys noticed, but the non-clinical stroke lecture basically came word for word from Pathoma. And so, she adds like a few things, like direct hemorrhages, but if you know the Pathoma stuff and he organizes it pretty well, then you can just skim through that lecture. You can have mild, moderate, or severe. What are the three, you definitely need to know this, what are the three areas that are vulnerable in the adult brain? Okay. So at layers 3, 5, and 6 of the cerebral cortex, the hippocampus, and the Purkinje cells of the cerebellum. And I don't know why they put this in this order, because I didn't do this slide. Hippocampus is number 1. Okay, focal ischemic infarction. So we have ischemic versus hemorrhagic are our two big categories. Within ischemic, we have thrombotic versus embolic. So thrombotic, the number is usually going to be atherosclerotic. So the number of places with atherosclerotic plaques are at the bifurcation points. And then we have embolic, which can be artery to artery, or it can be cardioembolic, which is almost always going to be caused by atrial fibrillation. These are often going to be seen at gray white junctions. If they're cardioembolic, a lot of the time the embolus will break up, and so you'll get like several small strokes at the same time. What's the number 1 artery for that? It's going to be MCA. And then the third etiology is small vessel disease. So this is hypertension. It can be arterial hyalinosis, which is this. It's also related to diabetes. The number 1 risk factor is hypertension, though. So that's something you can be asked. And this is shown here. So your thalamus is down here. So this is like the caudate, putamen, globus pallidus, all that stuff. So you can see all these holes in it. Those are a bunch of strokes. So there we have like there. And this is the caudate, sorry. The caudate with 6 strokes there. Okay, so lacunar stroke of the lenticulostriate vessels in the basal ganglia. Oh, sorry. Okay, so internal capsule is going to cause a pure motor stroke. Thalamus, pure sensory. Pons, dysarthria or clumsy hand syndrome, which is just like a weird specific pontine stroke. And subthalamic nucleus, what's that going to cause? Business. You guys are so smart. Okay. All right. And then for the histology of the ischemic stroke, this actually lines up like fairly well with the histology of an MI. So if you remember that at all, you can kind of just relate that, and you can get like the rough stuff. So 12 to 48 hours. Grossly, it's going to be pale, soft, swollen, and blurred. That picture's not big enough. And you're going to get dead red neurons. Red dead, I think is what they're usually called. 1 to 3 days, you start getting the necrosis, and you get neutrophils. And then 3 to 7 days, you get macrophages. So you can see this kind of lines up with the MI. There's macrophages. So 4 days to 3 weeks, gelatinous, friable, but you start to develop a distinct border, and you get the tissue liquefaction. So that is that. You can see like a pretty distinct border there. And you'll start getting vascular proliferation and reactive gliosis, which is the brain equivalent of scarring. More than 3 weeks, it becomes cystic, and you get hemosiderin staining, and you have astrocytic gliosis. So again, gliosis.
I have a question. So basically, while the patient's alive and they have the stroke, let's say 3 weeks later, we'll definitely see the cyst on the MRI.
If they, I mean, you will still see it on the MRI. MRI mostly measures like flow, so you're going to see like, I think it may be a different color, but I don't think you're not going to be able to see like, oh, it looks like that. You're just going to see it's lighter or it's darker, depending on what type of MRI you're doing. If they ask you this question, I'm guessing they'll either give you the time frame and then ask you in words, or they'll say, somebody had a stroke, and then sometime later they died. This is the picture of them on autopsy, and they'll say, how long ago do you think they had this stroke? That second way is how I'm guessing they would ask you. Okay, so collaterals are protections for stroke, right? Because the problem with the stroke is we lose blood flow, so if we have a different way to get blood flow, that's fantastic. The two collaterals that are important for you to know is the basilar artery, which is here, this big artery, and it's at the base of the brainstem because it's from the two vertebral arteries come together to form it. Can supply the MCA and the ACA via the PCA and the posterior communicating artery. So if you get like an internal carotid artery stroke, it goes internal carotid, and that makes the ACA and the MCA. So if you get a stroke here in the internal carotid, then you can get blood from the basilar going to the posterior, up through posterior communicating, and then it can supply those. The other one is the external carotid, can go through the ophthalmic artery, backflow through the ophthalmic artery to supply the intracranial carotid. Okay, so the symptoms of a hemorrhagic, so now we're moving on, hemorrhagic infarct. Symptoms are headache is going to be the big one, and then you get the other symptoms of ICP, or increased intracranial pressure, which is, so you get headache, you get nausea, vomiting, change in level of consciousness, confusion. Complications, the pressure and edema can cause ischemia, it can also cause herniations. So tonsillar herniation is here. Sorry, no, it's here. Hemorrhagic, and it can lead to hemorrhagic necrosis of the cerebellar tonsils, which can compress, and it can compress the brainstem and cause cardiopulmonary arrest. Remember, the brainstem is where the midbrain is where we have our cardiopulmonary control center. So if you compress that, mess it up, you get cardiopulmonary arrest. Subfalcine herniation is where the cingulate gyrus goes under here, and it compresses the ACA. You get ACA infarct. We have uncal herniation here, and that causes cranial nerve 3 compression, which is going to cause the down and out pupil. It can also compress the PCA, which can cause an occipital lobe infarct, causing contralateral homonymous hemianopsia, and it causes rupture of the paramedian artery, which is called a direct hemorrhage, and that's like pretty quickly fatal. You evaluate that by imaging, basically. All right. So talk about the different types of hematoma. So epidural, meaning above the dura, so it's between the skull and the dura. Location, so that's what's coming to the middle meningeal artery. So you learned about that last year. It's right here. It's usually somebody who gets like hit in the head with a baseball. And the reason is because there's the temporal bone right there, and so the bone can cut the artery. Presentation is they're totally fine, and then like bam, they die. Imaging is going to be the lens or concave. The way I actually learned this initially was lemon versus banana. And so the reason that you get that like more constricted concave blood is because the dura is attached to the skull at different points, right? So the blood can only expand from one connection point to the next. And so it ends up looking more like a lemon shape versus if you use subdural, it's the turning of the bridging veins, right? So it's between the dura and the arachnoid, and it can kind of spread across the entire hemisphere of the brain. So if this is the brain, it can go like that across the whole thing, and so it looks like a banana.
So it's basically outside the suture line for...
It's inside. So the suture lines are between the dura and the skull, and so an epidural hematoma has to stay between suture lines, but between the dura and the arachnoid, there are not suture lines. So that comes from tearing of bridging veins, and you're going to get progressive deficits. So for epidural, you're like totally fine, die. For subdural, you get like, progressively worse, and this can actually happen like subchronically. So it happens a lot of time to elderly people who fall because your brain naturally atrophies, and so the distance those bridging veins go between the dura and the arachnoid lengthens, and so it's easier to tear them. And so one way that this will present will be an old person who fell a month ago, and they've had progressive, like mild deficits since then. Okay, subarachnoid hemorrhage, the most common spot is the ACA and anterior communicating artery junction. It's often from trauma or from a berry aneurysm. It can happen if you're anticoagulated. It's the pathognomonic phrase for it is worst headache of your life. And the CSF is going to show xanthochromia, which is evidence of blood in the brain, and it just means like old blood cells. For the subarachnoid hemorrhage, you should know that like Ehlers-Danlos and like those conditions are associated with the formation of berry aneurysm. And do you guys remember the GI condition that's associated with that?
Is it I know the autosomal dominant kidney disease.
Yeah. You guys, several of you kind of said it together. The autosomal dominant polycystic kidney disease is also associated with berry aneurysms and therefore subarachnoid hemorrhage. Kind of a big step thing. Okay, intraparenchymal hemorrhage. Intraparenchymal meaning within the parenchyma, meaning within the brain. So a lot of times it's going to be in the basal ganglia. This is going to be from hypertension, and apparently Charcot-Bouchard microaneurysms are not actually a thing that exists, but according to exams, it's caused by Charcot-Bouchard microaneurysms. And then we have intraparticular hemorrhage, which is usually the germinal matrix beneath the ependymal cells, and this is going to be in a baby. Okay, so there's a hemorrhage, there's a hemorrhage. All right. Risk factors, that's not my phone. No risk factors for an ischemic stroke, if it is an atherosclerotic, so like a thrombotic stroke, then it's just the risk factors for atherosclerosis. If it's a cardiac source, then it's AFib. AFib is huge. Anyone who has a stroke is going to get checked for AFib. Like one of the immediate clinical things that you do is you do an echo. All right, and then hypercoagulable state can also cause it. There are a lot of things that cause hypercoagulable state, different types of anemia, and then a lot of autoimmune stuff like lupus, pretty much any of those like rheumatologic disorders. Hemorrhagic stroke, the risk factors are going to be hypertension, trauma, rupture of like an AVM or aneurysms, anticoagulation, obviously, cocaine can cause vasospasm, which I would think would cause an ischemic stroke. I don't know if that's wrong or I'm wrong.
I have a question. So for DVT, I know it was mentioned during our neuro lab that it can cause a stroke as well with DVT, especially if you have a patient cerebral valley.
Yeah.
Would it be a ischemic one?
That would be an ischemic stroke, yeah. So ischemic stroke means there's something blocking off the blood flow. Hemorrhagic stroke means that you're bleeding too much. So the DVT, so the way that happens is the thrombosis forms in your leg, and then something causes it to break apart. It travels up into the right side of your heart, and what they're saying about the reason you have to have a patent foraminal is because if it goes to the right side of your heart, if you have a normal, good wall between your two atria, then it'll go to your lungs and it'll cause a pulmonary embolism. If you have a patent foraminal then it can pass from your right atrium to your left atrium, then it can go to your left ventricle, go up your internal carotid, and cause a stroke. Okay, treatment. If it is thrombotic, you can give them TPA, which is tissue plasmin activator, so it breaks down the clot. You need to give this within 4.5 hours. The major risk of this is that it can cause hemorrhage. You also have an antiplatelet, so your options for this are like aspirin, clopidogrel, Plavix, so that is clopidogrel, and they need to be monitored in the stroke unit. You also need to control their blood pressure and blood glucose. For blood pressure, for an ischemic stroke, you can actually let the blood pressure stay kind of high because you want to keep forcing blood through vessels. For a hemorrhagic stroke, you really need to bring the blood pressure down. Prevention, obviously, like control the things that are causing it, right? So if it's thrombotic, control the atherosclerosis. You can do carotid endarterectomy. You only do that if they have symptomatic internal carotid artery stenosis that is 70 to 99%. You do not do it if they have 100% stenosis, and you do not do it if they are asymptomatic. And a stroke is a symptom, so if they have a stroke, that makes them symptomatic. Anticoagulate if it's a cardiac thing, and do antiplatelet if it's a thrombotic thing. All right. So cerebral venous thrombosis, so that's this, and this is showing the superior sagittal sinus, I think, and it's showing that it's like just not there, right? It's got blocked off. All right, thrombotic obstruction of cerebral veins with dural sinuses can happen at any age. Predisposing conditions, a lot of times happens in pregnant women. Also predisposed if you are on birth control, cancer, infection, especially if it's cavernous sinus, and systemic conditions. It's pretty non-specific symptoms, so it's a headache and the normal symptoms having increased intracranial hypertension. Most common is the superior sagittal sinus, which is that one that runs midline, runs right here along the very top. And that leads to hemorrhagic infarct and edema. Okay, now we're going to talk about how to localize a stroke. You need to have a basic idea of where these arteries are. So this would be the anterior spinal artery. Ventral anterior. And these are the vertebral arteries. So those run up either side of the vertebrae. Those come together. So pica is actually going to come off of those, and then those come together to form the basilar artery. So remember down here we're at the medulla. This is the medulla. Pica causes the medulla. Those form the basilar artery. Ica comes off of the basilar artery. So pons, medial is basilar artery, lateral is ica. Go up here, and then you're going to make the the posterior cerebral arteries, and then also the superior cerebellar arteries. And then you're going to have the posterior communicating that go up to meet with the middle cerebral. Middle cerebral comes off the ICA, and ICA also gets off the ACA, and then this is the anterior communicating. I wish there was a picture here. So it's kind of confusing the way it's named, but the anterior cerebral artery actually supplies the most medial parts of each hemisphere. The anterior 2/3 the medial part. So like my right ACA is going to do this, and my right MCA does this. Because when it's saying anterior and then medial, it's talking about medial front to back, not medial side to side. So anterior actually is the medial part of the brain. Medial, or the middle cerebral artery, actually does the lateral part of the brain. And then the back is all posterior cerebral artery. Also, weirdly, the inferior temporal lobes are posterior cerebral artery, PCA. Okay, so how do I know where stroke localizes? You know the homunculus, like I said, it's like hanging backward with monkey bars. Frontal lobe, we have frontal lobe motor area, and then frontal eye field, and then you also have Broca's area, which we're going to talk about language in a minute, and that's on the left side for the vast majority of people. Temporal lobe, you have Wernicke's area, again on the left side, and you also have the amygdala, which is your fear center. That's the thing. The Kluver-Bucy syndrome is bilateral amygdala destruction, and then the auditory cortex. So temporal is right by your ears, so it is here. Parietal lobe is going to do sensory and also just spatial awareness. So if you have a stroke in your parietal lobe, you can lose things like knowing which is left and which is right, all that kind of stuff. Occipital lobe is vision. Brainstem, you got to look at the earlier slides. Okay, so the lobular syndromes, if you have a frontal lobe problem, frontal lobe is also known as like the executive lobe. It's what makes us act like grown-ups. And so if you lose it, then you're uninhibited, you have poor judgment. Frontal lobe release signs is a return of like the infant reflexes. So you get like positive Babinski, you get like the grasp reflex, the Moro reflex, all that. You can also get Gegenholten. Here we go through this. So succeed grasp Babinski. Gegenholten is resistance to rapid passive movement. So the faster you passively move their limbs, the more resistance there is. And then gait apraxia, which is the motor cortex. So apraxia is I think the way that Dr. Gruner talks about it is like you can't access the file. So you're like physically, so gait apraxia means you forget how to walk. You're physically capable of it, you just don't remember, and so it's described as like being held before by magnets, because they'll get up to walk and they just stand there because they like legitimately cannot remember how to. Okay, temporal lobe. If you have bilateral, you can get amnesia because the hippocampus is in the temporal lobe, and that's the memory center. You get cortical deafness because, again, temporal lobe is right where your ears are. And you get Kluver-Bucy syndrome if you get destruction of the amygdala. Unilateral is the dominant side, you get Wernicke's aphasia. Frontal should also have that you can get Broca's aphasia. Parietal lobe, remember, just think sensory for the most part. So you get tactile agnosia. Those are both types of tactile agnosia, so it's not being able to recognize. So like if you put a cube in my hands and my eyes were closed and you asked me what it was, I would have no idea, and if I could look at it, I could tell you it was a cube. Agraphesthesia is, I have no idea how anyone figured this out. It's such a weird thing, but what that means is if somebody writes a letter on your hand, you can't tell what letter it is. So if somebody like, you guys remember you played that game like middle school where you like write a word on the other person's back and you have to guess what it is? Like they're very, very bad at that game. Okay, so the unilateral parietal lobe. Okay, you get anosognosia, which is unawareness of hemiparesis. So you get hemiparesis, right? Meaning like you lose sensation on one side. So if you have a right parietal lobe infarct, you'll lose sensation on your left side, but you also won't know that you did it, and you won't be aware of your left side. So if I had a right parietal lobe infarct and you grabbed my left hand and you said, Jacq, whose hand is this? I'd be like, I don't know. You'd be like, where's your left hand? I'd be like, I don't know. And you just think you completely ignore your entire left side. That is hemispatial neglect. Anosognosia is unawareness of the hemiparesis. You're like unaware that your left side doesn't work. And then you can also get dressing constructional apraxia. So gait apraxia is frontal lobe. Pretty much all other apraxias are parietal lobe. So like I said, you don't lose the physical ability to do something, you can't figure out how. So like you can't get dressed, you like do not know how clothes work. And constructional apraxia, constructional just means like activity. So like you can't learn like how to do stuff, you can't figure out how to do stuff. And then Gerstmann syndrome is if you get left-sided, and this is why I think neuro is so cool, because why are these four things together? So you get agraphia, meaning you can't write. You get right-left disorientation, meaning you don't know which way is right and which way is left, but you actually just don't know it like in reference to yourself. I wouldn't know which of my hands is my left hand, but I would know like that column is to the left. It makes no sense. It's the weirdest thing. Dyscalculia, meaning you can't add. Again, why? I don't know. And then finger agnosia. So you can't identify which finger is which. So if I ask like, what's this? I'd be like, I don't know, like my pinky? Like specifically, you just can't name which finger is which. It's like, it's so weird. But actually, thumb and pinky are not that affected. It's these three fingers that you can't really name. Because I guess these are just more distinct in people's heads. Okay. Occipital bilateral, you get Anton syndrome, which is where you have occipital blindness, but you don't know that you're blind. So, like, you think you can see. It's so weird. Prosopagnosia is where you can't recognize people's faces. Unilateral dominant is you can't name colors. All right, language. Language is pretty cool. So, Lyra, you can leave.
No, never.
So, so you have like the two main areas for language, right? You have Broca's and Wernicke's. So Broca's is in the frontal lobe, and it is the posterior inferior frontal lobe. So it's the back and it's the bottom. And if you remember, frontal lobe we talked about is motor, right? So Broca's, you have motor problems. So you can think of it as like your jaw is broken. Broca's jaw is broken. So you can't speak. And if you see like videos of these people, they actually, you ask them, you're like, how are you? And they're like, and they can't speak, and it's really, really frustrating because they're completely aware of the problem, they understand everything perfectly, their jaw is not actually broken, but they can't speak, and it's really frustrating. And then Wernicke's, which is the posterior superior temporal lobe. And again, we think about temporal lobe as hearing, right? And so I kind of think of it as like, it's kind of similar to not being able to hear. So they can't comprehend stuff. They have terrible comprehension. And they can speak totally fluently, but the things they say, like if you look at real life examples, it like kind of makes sense until you listen closely. Like mechanically they speak just fine, but they'll substitute syllables in, or they'll make up words, or the things they say just like won't make sense. And then you can get, and then you have the arcuate fasciculus, which connects them. And with that, you can get conductive aphasia, meaning you understand everything perfectly, you can speak perfectly, but those two centers can't communicate with each other. So the only problem you have is repetition. So for all of those, you have problems with repetition. The difference is with Broca's, you have problems with speaking, and you have problems with repetition. With Wernicke's, you have problems understanding, and you have problems with repetition. With the communicating one, your only problem is repetition.
Repetition as in what? Like you can't, like you...
So when you examine someone, you say, Danny, repeat this phrase for me. Okay. No ifs, ands, or buts.
Okay.
And you would mess it up.
Okay.
You raising your hand? No? Okay, I imagined it, sorry. Okay, you also need to know the difference between phonation and articulation. So phonation is the actual like production of sounds. So dysphonia is when you cannot, it's like the air through the vocal cords. And so that is done by cranial nerve 10, the larynx, and your lungs. And then articulation is the movement of your tongue and jaw and so forth to make the actual, to turn that sound into words. So that's 7, 9, 10, and 12 do that. So dysphonia is when you're like hoarse, you can't do phonation. If you can't articulate, it's dysarthria. Okay. So Broca's aphasia, like your jaw is broken. So this would be inferior frontal gyrus of the posterior inferior frontal lobe. Important thing to know about this is just that it's frontal lobe. And again, Broca's and Wernicke's are both MCA. So that's also important to know. Middle cerebral artery. Fluency, they're very non-fluent. They have telegraphic speech. Telegraphic meaning like when you were sending like a telegram, you had to use as few letters as possible. Poor repetition, intact comprehension, and they can also have right-sided hemiparesis. So remember that that's the frontal lobes. You got to think what else could happen if we have a left frontal lobe problem. Frontal lobe is motor, so we can lose right motor. Also, frontal lobe is inhibition and correct behavior, so you can also lose that, which is the frontal lobe release syndrome. Wernicke's. Superior temporal gyrus of the posterior superior temporal lobe. Again, just think temporal lobe. They are intact, fluent, but long sentences and paraphasic errors. Para meaning kind of, and phasic meaning like phrases is how I think of it. So they kind of say the right thing, but they'll either substitute different words or make up words. Repetition is poor, comprehension is very poor, because again, it's kind of like your ears aren't working. And they can, sometimes people just think they're drunk. All right, conduction aphasia. Arcuate fasciculus. They are fluent, but they have a little bit of a problem with it. Repetition, they cannot do. Comprehension, they can comprehend, but again, they have like maybe a little bit of a problem. It's closer to Wernicke's, but really, the way it's going to be given to you is that they're going to have maybe small problems with both, but for the most part, they're just going to be unable to repeat. Global aphasia is just when everything is knocked out, so you're not fluent, you cannot repeat, you cannot understand. Okay. Did you guys learn about the motor expressive episodia? The atrocities? Okay, cool. Never mind. Okay, brain death. Okay, you guys had a lecture today, and I wanted to send out the PowerPoint last night, so I kept the slides from last year's. I don't know if they changed it. If they did, obviously go by this year's lecture, like go by what they did this year. Evaluating for brain death, you need to do serial exams. The main things you're looking at are motor response, breathing pattern, pupillary and ocular movements. Motor response, if they withdraw from pain, they have cortical function. So one thing that's pretty easy to test is decorticate versus decerebrate posturing. So the way I remember this is if you're going to court someone, if you're going to like propose to them, you've got to flex, right, to like get the ring to propose. And then, so that's flexion of the upper, extension of the lower, and then decerebrate is extension of both. And then the way I remember where the lesion is these positions are the same, except for your hands are higher up in decorticate, and so I remember that it's physically a higher up lesion. So it's a lesion of the hemisphere versus a lesion of the midbrain for decerebrate. Okay, breathing patterns, that top one, A, so it gets up, 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 down, 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 so it's chain Stokes, so that's fancy way of saying it's alternate tachypnea and apnea, bilateral cortical depression, heart failure, or sleeping, if you're old. I actually saw somebody with this when I was on Neuro, and it was really cool to see it in person. I mean, it's sad, but it was cool. Hyperventilation can be caused by a lesion in the midbrain or pons, and then ataxic breathing, meaning they like don't breathe for a long time and then they suddenly breathe. It's impending respiratory failure, and it's a medulla lesion. Okay, I'm not gonna go through that. You can look at that. I'm not even sure you guys did it. Okay, seizures and epilepsy. So seizures, the brain is overexcited. So then what do the neurotransmitter levels look like? Well, you're gonna have more of the ones that excite it, like glutamate, and you're gonna have less GABA, which is what inhibits it normally, which makes sense, right? Epilepsy is when you have recurrent unprovoked seizures. So if you have like 10 seizures, but they're all because it's because you had 10 head injuries, you don't have epilepsy. You have epilepsy if you repeatedly have seizures for no reason. Unprovoked for a seizure in an adult, you have to do an EEG, of course. You want to do brain imaging because some of the things that cause seizures are like tumors or hemorrhage, all that stuff. You want to do labs, look for CBC, glucose electrolytes. You probably want to do a lumbar puncture. It's not required, but it's a good thing to do because also like meningitis can cause seizures. And then a urine drug screen because drugs can cause seizures. And one of the signs that something was a real seizure is that they have an elevated prolactin 10 to 20 minutes later. All right, so what do you get for seizures in different areas? Temporal lobe seizures cause what's called the epigastric aura, and that's because the amygdala, which is our fear center, is in the temporal lobe. So if the amygdala gets overexcited, then it starts making you think like something is going to go wrong, and that's what the epigastric aura is. It's like the feeling, the epigastric rising, like you have like a feeling in the pit of your stomach that something really bad is about to happen, and that's because your amygdalas are getting overexcited. You may also have contralateral limb posturing, and then MRI may show evidence of what's called mesial temporal sclerosis, which is sclerosis means like narrowing, right? So the mesial temporal area is just an area where if it like narrows or dries up, basically, it can cause seizures. And you can see that in old people a lot. Frontal lobe seizures are often at night. They have complex movements. Versive movements, meaning the head and eyes turn away from the seizure, because it's frontal eye fields. So one thing that you do need to know is that eyes turn away from a seizure and they turn into a stroke, meaning if you have a left-sided seizure, your eyes point to the right. If you have a left-sided stroke, your eyes point to the left. So the way that I remember this is that if you have a stroke, that is like an emergency. You want people to pay attention to you. You want them to look at you, right? So if a stroke happens, you're like, look at me, call an ambulance. If you like had a seizure disorder and had seizures all the time, you probably don't want people like staring at you, right? So you'd be like, look away. So if you look away from a seizure into a stroke. That's the way I remember it. Do whatever works for you. So frontal lobe, because it's motor, you can also get the Jacksonian march and the Todd's paralysis, which those were definitely both mentioned in your lecture. But again, if you just remember frontal lobe is motor, you have a bunch of motor symptoms, you have a good guess. Parietal lobe doesn't happen a lot, but it causes hallucinations and sensory changes. Occipital lobe is vision, it causes visual changes. Okay, so what are the different types of seizures? I would be super, super surprised if you did not get a question on this. Simple partial means partial, so it's only in one area, so it's just a temporal lobe seizure, it's just frontal, it's, whatever, so you only have like the symptoms from one thing, and there's no change in consciousness. So you gotta compare that to complex partial, which is also in one area, but you have some change in level of consciousness. That does not mean that you're passed out for 20 minutes. It means like maybe you get drowsy, or maybe you get confused, or maybe it's like absence where you zone out. And then you can also have partial seizures that secondarily generalize to tonic-clonic, meaning it starts as a partial seizure and then it becomes full-on tonic-clonic. Okay. So then we have generalized seizures. So absence is going to be the one that you hear about in little kids. stare up in his face for less than 10 seconds, it happens at least 10 times a day, and then as you know, the 3 Hz spike and wave on EEG is like a pathognomonic phrase, and you treat it with ethosuximide. So you definitely need to know treat it with ethosuximide. That's the thing that Dr. McCoy made that really stupid joke that was like, this is first aid mnemonic, but I think you should just remember absent seizures are treated with ethosuximide. And then myoclonus is shock-like movements. So juvenile myoclonic epilepsy is myoclonic jerks. They oftentimes happen in the morning in teenagers, and they're increased if you use alcohol or if you have sleep deprivation. And a lot of the time will be bilateral, so it'll just be like their arms will just jerk like that. Atonic, so A meaning none, tone meaning tone, so you lose tone. So it can either be focal or involve all the muscles, and you have brief loss of consciousness. Tonic-clonic is what we think of as like a seizure. You can't have an ictal cry, you can pee. They have prolonged post-ictal confusion. So that's one of the ways that you can differentiate it from like somebody passing out from like a vagal response. Oh yeah, so myoclonic is treated, so like the juvenile myoclonic epilepsy is treated with valproic acid. So when would you not use valproic acid? Yeah, pregnancy, or if you think they might get pregnant. So I did the like peds neuro rotation, and this girl had been on valproic acid for a long time, and she was like 16, and so the neurologist was telling her mom, like, we need to switch her over to this, because regardless of whether you want to think of it this way or not, she is physically capable at this age of getting pregnant, and you cannot have someone of childbearing age. You should not have someone of childbearing age on valproic acid, a woman. Okay, febrile seizures, they happen in little kids. The most important factor is the rate of rise of the fever. That's the thing that's most likely to predict whether or not you have a febrile seizure. In order for them to be simple, you can only have one in a 24-hour period. It has to last for less than 15 minutes. And this is this thing where he says like the first seizure is free. You don't have to work up a febrile seizure, like a first-time seizure in a little kid. Okay, status epilepticus is a really big deal, so it's like the opposite of febrile seizures, where you seize for 30 minutes straight, or you have more than 2 in a row without regaining consciousness in 30 minutes. So you need to give them lorazepam to break the fever, and then you give them phenytoin to stop another fever from happening. Okay, read this. Okay, so it's going to be complex partial, because it starts partial, right? But he has a change in consciousness. All right, dementia. I think it's super interesting. So you do need to know the difference between dementia and delirium. Delirium is reversible, and the biggest things you're going to see, like the easiest way you can identify this in a test question, is it's like acute onset often, and a lot of times it's going to happen like after somebody had surgery. So you're not going to expect like an Alzheimer's patient to be totally fine and then have surgery and then suddenly be super confused, right? That's not how Alzheimer's presents. It's not a post-surgical thing. So delirium is going to be abrupt onset, it's going to fluctuate, and it's completely reversible, versus dementia, which is like milder onset and irreversible. Okay, so incurable causes of dementia, Alzheimer's disease is the most common. There's vascular dementia, which is going to be the stepwise decline with focal abnormalities, because that basically is just a bunch of strokes. And so the way that that's going to present is somebody's like totally fine, and then, you know, their memory like goes a little bit, and then like all of a sudden they get really bad at math. And then a few months later, they all of a sudden like develop a tremor. But we'll have to make it pretty clear to you in the question that this was a stepwise thing and not like not a gradual progression of something like Alzheimer's. And they'll also, like, the abnormalities will be more focal, because like Alzheimer's also gets worse, right? Like it starts with short-term memory, and then it goes to long-term memory, and then it gets like motor, but it's a known progression. Okay, and then you have Lewy body dementia, which is associated with sleep disorders. So it's associated with like restless leg syndrome and some other sleep disorders, and with neuroleptic sensitivity. It begins with dementia and visual hallucinations, and it's followed by Parkinsonism. So Lewy body dementia and Parkinson's have like a similar pathogenesis. The difference is with Parkinson's, you get like all the motor stuff early, and then you may eventually get dementia. With Lewy body, it starts with dementia, and then you can develop motor symptoms. And visual hallucinations, if they're talking about dementia and they say visual hallucinations, it's almost definitely Lewy body dementia. Okay, Parkinson's. So the 4 things for Parkinson's, the mnemonic word is trap. So tremor, it's a resting tremor. rigidity, cogwheel, akinesia, which it could be bradykinesia or akinesia, which it just means you move slow or you don't move, and then postural instability, meaning it's super easy to like push them over. Not a very nice way to test them. But. And they also have the shuffling gait and the stooped posture. It's caused by decreased dopamine due to deterioration of the substantia nigra. So the treatment is to increase the dopamine. So that can either be like levodopa, carbidopa, or it can be COMT inhibitors. You know, you guys learned about all their medications. I'm not going to go through them, but the end point of all of them is increased dopamine. You can also have frontotemporal dementia, which is Pick's disease. So frontotemporal, it affects the frontal lobes and the temporal lobes. So frontal lobe, again, is behavior, inhibition, executive function. So you can get, so that starts with the change of personality and social conduct and disinhibition. So the way this is going to start is it's going to be like, John is a pastor in his church. He's a pillar in the community. Everyone loves him. He's very polite. And then all of a sudden, recently, he started making super sexual comments to his neighbors. And you're like, oh, that's not a very nice job. And that's because he has frontotemporal dementia. The second time is language deficits, so you get aphasia, meaning you don't speak. And you do, it is dementia, right? So you do also get memory problems because the temporal lobes, that's where the hippocampus is. And then we have Creutzfeldt-Jakob disease, which happens in younger people. This is the prion disease, and it's rapidly progressive. So it will be they are fine. 1 month later, they don't remember their own name. Okay, and then Huntington's, autosomal dominant triplet expansion on chromosome 4, so it's CAG. My mnemonic that I used for this was C for caudate degeneration, A for decreased acetylcholine, and G for increased glutamate. And there's also decreased GABA. The caudate degeneration and the decreased acetylcholine lead to the chorioathetosis, which is just talking about like writhing movements. So they just kind of like do this all the time. And it often ends in suicide, and it happens younger in each generation. And then there's AIDS dementia. Okay, Alzheimer's disease. Familial is autosomal dominant, and then the genes for that, presenilin 1 on chromosome 14, presenilin 2 on chromosome 1, and then the APP, which is on chromosome 21, which is why early onset Alzheimer's happens in Down syndrome patients, because APP is on chromosome 21, they have an extra chromosome 21. Sporadic is from ApoE4 leads to increased risk, ApoE2 is protective. And then the pathology, the neurofibrillary tangles are intracellular, and they are made of hyperphosphorylated tau. And then amyloid plaques are extracellular, and they're made of beta amyloid. So you need to make sure you know which one of those is intracellular and which one is extracellular. Okay? This is what the brain looks like. So it atrophies, and so you're going to get expansion of the sulci and shrinking of the gyri. Clinical presentation, problems with memory, and then that's going to go to a decline in intellect. It's going to lead to aphasia, apraxia, and agnosia. And then eventually you can get impaired judgment, personality changes, incontinence, and terminally they will be bedbound. Diagnosis is clinical. It's a diagnosis of exclusion. The rule used to be that it could not be formally diagnosed except for an autopsy. They can now actually look for levels of amyloid and tau protein in the CSF, but I don't think it's not commonly done. Treatment, central acetylcholinesterase inhibitors to slow deterioration, so donepezil, rivastigmine, galantamine, and then NMDA antagonists, memantine is the big one there, and then sedatives and antipsychotics. Okay, you definitely need to know this table. So just for all of these neurodegenerative diseases, whether they are alpha-synucleinopathies, whether they have tau proteins, all that stuff, I'm not going to go through it because there's no, it's not conceptual, you just gotta memorize it. Okay, pathology, so these are PIC bodies, amyloid with the green stain thing, neurofibrillary tangles, and then there's your Lewy body. All right. is just normal, this is just normal aging. If somebody has Alzheimer's, their family member is gonna come to you with concerns. They are not aware of their memory problems. Also, these are like super normal things to forget, right? And MMSE, I believe 24 and below counts as like mild cognitive impairment. All right, tumors. This is tumors, so there's a lot of them in the gray white junction, and then also you can see it's like multiple, so that tells you it's also probably tumors. Okay, so presentation, they're gonna have headache, nausea, vomiting, seizures, syncope, cranial nerve palsy. So basically they're gonna have symptoms of some big stuff pressing on their brain. In an infant, because the suture lines haven't closed, their head will actually get bigger and their fontanelles will bulge. Diagnosis, you're gonna do an MRI, and then that's gonna lead you to do a biopsy when you find the mass. Spread is often via subarachnoid, treatment, surgery, radiation, and chemo. Depends on what kind of tumor it is. So childhood tumors, brain tumors are the number one solid tumor of childhood, because the number one cancers of childhood are like the blood cancers. So the important thing to remember is that 70% of the childhood brain tumors are infratentorial, and the way that I remember that, that means they're below, and kids are shorter, so it's lower down. Adults, they're supratentorial. So a tumor of astrocytes would be the pilocytic astrocytoma, which is the most common, and it is benign. Ependymal cells make ependymomas, which are malignant. Neuroectoderm makes medulloblastoma, which is malignant, and then Rathke's pouch makes the craniopharyngioma, which is also benign. Adult tumors, as I said, 70% supratentorial, so above the tentorium, because adults are taller. So astrocytes make glioblastoma multiforme, which is malignant, and it's number 1. Oligodendrocytes make oligodendroglioma, glioma. Neurons make meningioma, benign. Schwann cells make schwannoma. Metastatic tumors, where are they usually? Gray white junction. You got the next question right there, yeah. Primary source is lung, breast, melanoma, kidney, GI. And lung and breast metastasize like everywhere. So if you ever get a question of like what's the most, like where's the most likely primary site of this cancer, lung and breast are 2 good bets. Okay, so buzzwords you need to know. Which ones are S100 positive? Come on, wake up. We're almost done. Schwannoma. World pattern with Samoma bodies. Samoma and whorls for middle-aged girls. Meningiomas. Okay, small round blue cells. Medulloblastoma. Butterfly lesion. Glioblastoma multiforme. Fried egg appearance. Yeah! Right there, Danny's got me. Alright, bitemporal hemianopsia. We talked about this earlier. What causes that? Pituitary craniopharyngioma. So it can be either. So if we're here talking about craniopharyngiomas, remember that's something pressing on the optic chiasm. Rosenthal fibers. Pilocytic astrocytoma. Good job, guys. Pseudopalisading and endothelial cell hyperplasia. Glioblastoma. So I remember her like kind of emphasizing this endothelial cell hyperplasia thing, and I think Pavoma does too. If you guys have sketchy path, I thought sketchy path was super helpful for these. Like in general, I think like cancers are the thing that sketchy path is the most helpful for. I don't think you should try to learn conceptual stuff through sketchy path, because I think you're like doing yourself a disservice if you do. But for stuff that there's like no concept to, it's just straight memorization. For this specifically, for the brain tumors, I think it's worth it. All right, drop metastases. Medulloblastoma. Hydrocephalus. Ependymoma. Adult tumor more common in women. Yeah, Samomas and whorls for middle-aged girls. NF2? Yeah, schwannoma. Seizures in adults. Can be pretty much anything, but in women it's usually meningioma, the other one is oligodendroglioma. Then biphasic is the pilocytic astrocytoma. Okay, read this. Okay, so it's E. So middle-aged woman with the first seizure, and And we see this, so we think it's brain tumor, right? Because we're in the brain tumor section. So the reason I put this on here is because you can see this dural tail right here. So that's another characteristic of the meningiomas, is they have that tail on the outside that connects to the dura. And so this is, again, that Simoma's the world's for middle-aged girls. Okay. So here is, I think this was the world and this was the, no, these are Simoma. These are worlds. All right. Again, you guys can leave. Why? Yeah. All right. CNS infections, they are ring enhancing, the abscesses. Okay, so bacterial meningitis. I put that table and this other thing because if you look at like Christopatus versus the woman whose name I can't remember right now versus like Dr. Gruner's lectures, they gave separate, slightly different things. But you need to know in general what are the most common etiologies of bacterial meningitis in different age groups. So 0 to 6 months. Bi-pneumonic for this is baby bell. So group B, strep, E. coli, and listeria. So BEL, baby bell. 6 months to 6 years, strep pneumo, and meningitis, H. flu. 6 to 60, strep pneumo and meningitis. And then 60 plus, strep pneumo, gram-negative rods, and listeria. So this isn't too hard because you just remember the strep pneumo is for all three of those. Meningitis, if you remember that like people get it in dorms, then you can kind of remember that it's like the middle areas. And then H. flu, just remember that in Sketchy they're all little kids. For old people, gram-negative rod, I just think of the rod as a cane. And then listeria, again, if you remember the Sketchy Santa was old. So the signs are the Brzezinski sign, Koenig sign, and then you can do an LP to look for it. This is bacterial meningitis that's like beautiful over the brain. All right. Treatment, broad spectrum antibiotics empirically, so you want to give cefotaxime or ceftriaxone plus vancomycin, and then ampicillin if you're worried about listeria. So if they're really young or really old, you also give ampicillin. You can also give dexamethasone, so that seems like really counterintuitive, right? Like generally you're not going to give steroids if someone has an infection. But dexamethasone is actually really good for decreasing rates of deafness in children post-meningitis. So some of the complications you get are hydrocephalus due to pus obstructing the CSF. You can get meningoencephalitis, infarction, and then deafness is a complication you definitely need to know. So especially for little kids, meningitis can cause deafness, so we do dexamethasone to stop that. Histology, gross, the exudate, creamy to subarachnoid space, and its future dose. All right, chronic. Happens over weeks to months. It's usually going to be in elderly people who are malnourished. It doesn't necessarily have meningeal signs. It's not necessarily going to have your like neck stiffness, Brzezinski, Koenig's. It's usually going to have like a headache and confusion. It's often caused by tuberculosis, which has the necrotizing granulomas. So it's the same as like what happens in the lung. And this is tuberculosis. It also causes this like goo there. I don't know why. And then some fungal things. They're usually coming from the lung. Complications of this: vascular invasion or thrombosis can cause infarction. Mycotic aneurysm rupture can cause hemorrhage. So the number one fungi that causes this is Cryptococcus. You find this by doing an India ink stain. The histology is going to be these clear cystic lesions. So it's these, like the Swiss cheese things, in the basal ganglia and thalamus. So this is our basal ganglia and thalamus here. And it's going to be in an immunocompromised patient. And this is the India ink stain. Okay, and then blastomycoses are the yeast, so you gotta remember what those look like. And then aspergillus, the stain for that is the silver stain. And then you get the septate hyphae. Sorry. You get the septate hyphae. So look like there. I can't see very well in that picture, but it's all these lines. All right. Chronic meningitis. So parasitic, the number one is going to be cysticercosis. So if you remember like the Neuro cysticercosis. And you get that because somebody else poops out the eggs and then you come in contact with their poop, and you eat food that came in contact with their poop. In the image, you find a cyst that it can show the scolex, which is the skeleton inside it. The number one symptom is seizures, and that's caused by the death of the parasite. And this is what they look like. This is also a cysticercosis thing. So you see they got these holes. Okay? You can also get it from toxo. So toxo, the classic triad for toxoplasmosis is the chorioretinitis, hydrocephalus, and intracranial calcifications. So that's going to be from cysts in meat or oocysts oocysts and cat feces. It's usually due to reactivation following immunosuppression. So if you remember, like this is something that happens in people with HIV, which is why they're on Bactrim or TMPS-MX to try to stop that. It's also a torch infection, which is why there's a whole thing with like pregnant ladies should mirror on cats. And it has a ring-enhancing lesion. You can also get the amyobiasis, the Naegleri fowleri, which comes in through the cribriform plate when you're swimming, and it's usually fatal. I thought I had a picture. Oh, it's later. Okay. Viral meningitis, most commonly from viruses in the enterovirus family. Histology, grossly, it's normal, which is like the same thing we think of with any viral infection, right? We don't have the neutrophil response, we don't get the pus. Microcytically, you get this lymphocytic exudate into the Virchow-Robin spaces. Okay, neurosyphilis causes aseptic meningitis. It can also cause meningovascular syphilis, which is the obliterative endoritis. So basically, it obliterates arteries, causing the syphilitic stroke. You can get thickened meninges, which can cause hydrocephalus because like they thicken and they block the exit, and it can cause cranial nerve palsies. You also get parenchymal neurosyphilis, which is really what we more think of as neurosyphilis. So the general paresis, psychosis, and dementia. And then tabes dorsalis, which we talked about. The thing to remember about this is that the psychosis and dementia on histology, there are a lot of spirochetes. And the tabes dorsalis, you have no spirochetes. This is like 30 years later, like they're all gone. And I remember her emphasizing that, so it was probably worth knowing. Okay. Lumbar puncture. So for bacterial, you're going to have a bunch of neutrophils. You're going to have really high protein. You're going to have low glucose because the bacteria are eating all the glucose. For viral, you're going to have an increase in cells, not that many though, but it's going to be lymphocytic. And viruses don't eat glucose, so it's normal. TB, it's like, I don't know what's up. This got like shifted or something. You just need to know bacterial and viral. And then if you only get one drop of CSF, culture is the most important thing. All right, encephalitis. So encephalitis is infection of the brain in the way that meningitis is infection of the meninges. So it's a primary infection and inflammation of the brain parenchyma. It usually happens with meningitis. It can be diffuse or regional, but it generally affects gray matter more than white matter. It's usually from like a tick, like Lyme disease or something. The micro, you get the perivascular lymphocytic infiltrate, so that's here, so it's all these lymphocytes. Neuronophagia, which is the dying of the neuron, and then microglial nodules, which I believe is there. Okay, signs and symptoms, you get fever and headache, seizures, vocal neurodeficits, and changes in behavior, and you might need to give dexamethasone to treat the ICP. All right, the viral infections. Herpes simplex, this is something that's really important that you can recognize. Super, super, super common, like #1 cause of infectious encephalitis in the US. It has a really strong predilection for the frontal and temporal lobes, so it causes hemorrhage there. So it can knock out both of your hippocampi, and it can cause permanent memory loss. Histology is the alveoli, and because this is like so serious and it happens so quickly and it can knock out your entire memory, you give empiric acyclovir if you at all suspect that this could be happening. Okay, West Nile virus you get from the birds. The symptoms are you get the polioencephalomyelitis and Parkinsonism. Predilection for anterior horn cells, nigral neurons, and Purkinje cells. Polio is actually still endemic in South Asia and Africa, and also in like Pakistan, Afghanistan. So if you get a question on this, it's either going to be an immigrant or it's probably going to be an immigrant because we don't even have to give polio. Like, polio is just like not here anymore. Super important thing to know about this is that it does gray matter only, and it's the anterior horn cells, which is why you have motor problems, and it affects the lower extremities much more than the upper extremities. So you can remember this because like Roosevelt had polio, right? He's in a wheelchair, so it affected his lower extremities. And then post-polio syndrome is you're gonna have a late onset of weakness of previously recovered muscles. So like I saw a lady on Family Med in clinic who, she was like 85 and she had leg problems, like from having polio when she was like 6. Okay, shingles is reactivated varicella. You're gonna have a vesicular rash. So they'll have a really painful rash and it'll be along a dermatome, which means it won't cross the midline. Okay, CMV is a torch infection. The histologies, you're going to get the intracranial calcifications, and you'll get intracytoplasmic and intranuclear inclusions. Rabies, you get it from rabid animals. You get a flu-like prodrome, and then you have photophobia, hydrophobia, which is weird. You're like averse to water, paralysis, coma, and death. And then you need to be able to recognize these bullet-shaped rhabdovirus and also the Negri bodies. Okay, and then Zika. We're not really worried about like people getting Zika because it basically just causes the flu. But congenital, it can cause infants to have microcephaly, brain abnormalities, ocular findings, congenital contractures, and neuro impairment. Okay. Then there is the HIV diseases. So hive is one of them. So it's like direct infection of the CNS with HIV. Infects the gray matter, and it causes microglial nodule encephalitis. And the important thing to know here is it causes these multinucleated giant cells. You can also get AIDS dementia. And so the way this will present is, like in a test question, it'll be somebody in like their 30s with dementia, and it'll be someone who's like never really had health care, and they'll have to give you some mention of why they would have gotten AIDS. So like they either had a history of IV drug use, or they may have been like a sex worker, like somebody who would be a high-risk AIDS population. Okay, and then vacuolar myelopathy. See if we have a picture. Nope. Okay. So vacuolar myelopathy like degrades parts of the spinal cord, so you have spastic unsteady gait, upper motor neurons, hands and legs, impaired proprioception, so we have like dorsal column, corticospinal tract. Histology is patchy demyelination of the dorsal column and the corticospinal tract. Okay. You need to know this PML, so this is what we're talking about, can be increased by natalizumab. So it's a reactivated JC virus, and it's going to infect the oligodendrocytes. So we are all infected with JC virus. It's just if you have a normal immune system, it's not an issue. So you see this in people who have AIDS and people who are on immunosuppressants. Presents like rapidly progressive MS because they just get demyelination in like random spots. So they're going to have all these like, seemingly unconnected problems. Imaging asymmetrical white matter demyelinating lesions. This is one of the few that's non-enhancing. So that's like definitely worth noting. Okay, histology, again, patchy demyelination, microscopic, they have bizarre astrocytes. I still don't know what that means. Tried to figure it out last year. Oligodendroglial inclusions that are ground glass, and then foamy macrophages. Diagnosis, you look for JC virus. Some other things that they're at high risk for are the toxo, cryptococcus, and CMV.
What do you mean by non-enhancing?
It means when you give contrast, it doesn't light up. All right, abscesses can be localized or encapsulated. They're usually bacterial, so which type of bacteria would cause it? Staph and strep. All right, so risk factors, diabetes, so you are considered to be immunodepressed if you are diabetic. So diabetes is immunosuppression. And then also alcohol and just general immunosuppression. Diagnosis, ring-enhancing lesion. And you can biopsy it because just from the MRI, you can't necessarily tell whether that's an abscess or a tumor. Symptoms, you get a headache, seizure, focal neurologic signs, or you can also get abscesses in your spine. Treatment, you have to excise it and give antibiotics. Okay, now we are going to do the histology. So what do you think this is? Negri body and a Purkinje cell, so it is rabies. Okay, this one. It's an abscess, so this is like the purulent exudate from it, an abscess. Okay, what do you think these are? Yeah, they're abscesses. Okay, this is the vacuolar myelopathy for HIV. So this is the dorsal column degradation, and this is corticospinal tract getting affected.
How do you know that it's not vitamin B deficiency?
It's not on the list. Okay, what are these? So rabies, so these are the bullet-shaped rhabdoviruses. Okay, what are these? These are intracranial calcifications, so it's CMV. Okay, alloy nuclear inclusion, so that's going to be HSV. What's this? Multinucleated giant cell, you need to be able to recognize this. This is HIV encephalitis. What's this? exactly. CMV inclusions. So this is what I was saying is the intranuclear inclusions. Okay, and then what do you see here?
Hemorrhage. Temporal.
This is a hemorrhage. Where is it in the brain?
Temporal lobe.
The temporal lobe. So what did we say causes temporal lobe hemorrhage?
HSV.
Temporal hemorrhage is due to herpes simplex virus. That's something you definitely need to know. Herpes simplex virus encephalitis can cause temporal lobe hemorrhages. Okay. Prion disease, you guys know what this is. All right, lead poisoning. If you have adults, lead poisoning is going to cause peripheral neuropathy, and the way this question is going to be asked is they're going to work in a factory. A lot of times it's going to be a battery factory. In kids, it causes encephalopathy, anemia, and abdominal pain, and they're going to have to mention something about them being in low-income housing or in an old house. Treatment, chelating agents. This is the first aid mnemonic for lead poisoning for kids. So lead lines, the line on the bone on the x-ray, encephalopathy, anemia, abdominal pain, wrist drop, foot drop. Okay, organic solvents are huffing glues that cause encephalopathy and peripheral neuropathy. Tetanus comes from soil or from wounds with rusty metal. Mechanism, so if you remember, tetanus causes like the hypercontractures, right? Like you can't relax your muscles. And so the exotoxin is blocking the release of inhibitory neurotransmitters. So you can't inhibit anything, so you cannot relax your muscles, which is why you get this thing, the opisthotonus and the rhesus sardonicus. So spastic paralysis, arching back, lockjaw, generalized seizures. Treatment is ICU care, sedation, and tetanus antitoxin. So eventually it'll pass, you just gotta like take care of them. So botulism, in adults it's getting improperly canned food, and the way that you'll see this is a whole family will get sick after like going on a picnic, and a lot of the time it'll be everybody got like stomach food poisoning, but grandma got paralyzed. Because grandma doesn't have a good immune system. In infants, it's the spores and it's in honey, which is why infants are absolutely never supposed to eat honey. Okay, mechanism, exotoxin binds to presynaptic nerve terminals, preventing acetylcholine release. So this is the opposite. So tetanus causes you to not be able to relax. You got this thing. Botulism causes flaccid paralysis, and if you remember from the sketch sheet, it's top down, and so they have, like this. So it's flaccid paralysis because tetanus makes you not be able to release inhibitory neurotransmitters. Botulism blocks excitatory, blocks the acetylcholine. Flaccid paralysis, the treatment is the antitoxin. Okay. Alcohol. So you get Wernicke's encephalopathy, which is caused by thiamine deficiency, and it's going to cause mammillary body atrophy. So that's this. Okay, the triad, it's KNO beer, so confusion, ataxia, nystagmus. And then Wernicke's is the first part of it, and then it can progress to Korsakoff, which is loss of memory with confabulation. So they don't realize that their memory loss is happening, and so they just make stuff up. You also get cortical atrophy. You obviously can have acute intoxication. We all know what alcohol does acutely. And then withdrawal, you need to be able to recognize early withdrawal, so it's a hangover. So it's like dry mouth, it's tachycardia, it's hypertension, because alcohol is a sedative, right? So it slows everything down. And so when you drink chronically, your body compensates by increasing all your excitatory stuff. So if you remove the alcohol, you now have more excitatory, but it's not being inhibited. So you just have more excitatory. So you get the tachycardia, the hypertension, and you're just like down. You can't sleep. So important thing to be able to recognize this, a lot of the ways this will be asked, is somebody will come in for surgery, they're like totally cool, and then 3 days later they have a seizure, and the reason is because they're an alcoholic, and by being in the hospital, you put them into withdrawal. So the 12 hours to 3 days, they can get seizures. Delirium tremens is 3 to 4 days, they get fluctuating motor and autonomic activity, confusion, hallucinations, which is called delirium. And the treatment acutely is thiamine and then dextrose, because they have thiamine deficiency, and you give them dextrose because they're also like hypoglycemic because of it. And then to stop the withdrawal symptoms, you give them benzos. Okay, methanol. So methanol is oxidized to formaldehyde and formic acid, causes global hypoxic injury, white matter necrosis, and hemorrhage of the putamen, which is what you need to know. Then you use severe acidosis, optic neuropathy, blah, blah, blah. Okay, carbon monoxide, headache, vision changes, dizziness, weakness, and vomiting. That's going to proceed to cause the chest pain, confusion, and weakness. and then eventually you get arrhythmias, loss of consciousness, seizure, and death. It causes cerebral edema and the white matter petechial hemorrhages, which is these, so you need to be able to recognize those. And necrosis of the this is the necrosis of the globus pallidus. Treatment is the hyperbaric oxygen chamber, because remember you're trying to compete the carbon monoxide off of the hemoglobin. Okay, osmotic demyelination or central pontine myelinolysis. So this is if you try to correct hyponatremia too quickly. So you need to know the difference between what happens if you try to correct hyponatremia too quickly versus trying to correct hypernatremia too quickly. So low to high, pons will die, high to low, brain will blow. So low to high, meaning you correct hypo too quickly, you get the central pontine myelinolysis, so you fuck up the pons. High to low, meaning you correct the hypernatremia too quickly. What happens is that the cells are still hypernatremic, so when you make the blood really hyponatremic, the cells absorb all the fluid from the blood and they all blow up. And so you get like really bad swelling in the whole brain. Okay, so the symptoms: rapid onset of extremity weakness, confusion, gaze palsy, hypotension. Basically what you need is you get locked-in syndrome, meaning you are completely aware, you can move your eyes, but you cannot move any other part of your body. It's horrible. Okay, and then you have Wilson's disease. So in Wilson's disease, you can get Parkinsonism because the copper... Are you raising your hand?
No, sorry.
Oh, no, you're fine. I just couldn't tell. The copper can deposit in the basal ganglia, and remember the basal ganglia is where Parkinson starts and also causes all the movement disorders, so you can get like some movement problems.